Good afternoon, senior members of the faculty, colleagues and friends. I see some of my bosses laughing because every time I'm here, I'm in a new college. And I don't know how Dr. Jayakrishnan has chosen this talk for me, because after working in the government for 20 years, I'm at last in a very small college, a very new college, and having to do things differently and for once in the way I would like it to be. So I thought this was very, very appropriate. We have very few deliveries. We're just making a few steps forward and we're trying to do our best. So the talk that I've been given is making labor comfortable. This is what I would like to think that all of us would follow. Childbirth is a unique event which should provide a sense of profound and lasting satisfaction for mothers, in which we as doctors and midwives should count ourselves fortunate to share. But are we really there? For us, it's just another delivery. Let's face it. So what are the home truths? This is something that I got when I was working in SAT. We did there we have about 800,000 deliveries a month. And the women said that there is no place as lonely as the busiest labor room. Because everybody is very casual to just another labor. They said they felt sad about curt tones of voices, looking at the blood-stained glove. And we're talking about water births. There we have no beds for the births. We have 3 and 4 in one bed. So mindless exposure in an indelicate position. And very often we do vaginal examinations but never tell the patients where they are. So, or failure to convey the results of a vaginal examination. So are we preparing our antenatal women? I would say not at all. The women, some of them are very young. They don't know where the baby came from and where it is going to come out from. So there is a total neglect of antenatal preparation. I have to tell you this because I'm proud of it. In Paripalli in Kollam, we have antenatal classes the first Friday of every month, and our women know what they have to do when they come to the labor room. It's not this, we have about 80, 90, we have the mothers also with them. Shamla madam, we'll have a talk after this. The mothers are there as well, not the husbands because we don't have that facility as yet. But the mothers are also there. They know a lot of things. So what do we discuss at these classes? Basically, everyone wants to know, yes, they know that there's going to be pain. How long is it going to last? How painful is it going to be? And I must confess that we have an excellent team of anesthetists who keep hovering around us. Do you want labor analgesia? Do you want labor analgesia? We've done 3 so far. And I'll say we're the first medical college, the government medical college, to do labor analgesia. That's epidurals. So what should they expect in labor? What is their diet? What is their exercise? Are we going to offer them some form of pain relief? How should they come in labor? What they should bring with them? See, I work in a government background. So they can't run around for things to their houses every 5 minutes. So we tell them, you bring 5 sets of mundas, 5 sets of blouses. The mother also wears a white munda and white blouse so that we're sure that she's clean and neat when she comes into the labor room with her daughter. And also tell them what are the warning signs in pregnancy. So we don't have women coming every 10 minutes with decreased fetal movement. They know that how to count the movement. They know what is labor pain. They know how it starts. Of course, we have quite a few false labors, but that is as it should be. Companion in labor. I know in SAT we tried our level best to start this system. We still haven't taken off there. Paripalli, as I told you, we are a much smaller place, so we do allow the mothers, they choose their companion in the first trimester. It could be their sister, it could be their aunt, it could be their mothers, somebody who comes with them for classes, and we tell them also what to do. And very often we found that these girls who come in labor, they said, I don't want my mother to be there. She'll get worried, she'll get scared, and very often they say, my mother has delivered 4 times, but she doesn't know anything. So I'd like to have my cousin, I'd like to have my sister, fine. So we tell them what you should do, how to massage their back. You know, when you tell them, pat their back, they either do this all the time or they do this all the time. We tell them slow pressure on the back. These are small things. And let me tell you, why don't we have epidurals is because these women are quite comfortable this way. They don't want the epidurals. So the companion in labor, I think it should be a system that we all practice. There is a fear of isolation in these circumstances, and I am sure all of you will agree with me when I say that medical efficiency and humane considerations are just not compatible. We can't do everything for them at the same time, pat them, rub them, talk to them. We may not do all these things. So we need somebody else to do these things for us. So you need to guarantee that personal attention throughout labor, one-to-one, face-to-face. Mere physical presence is not enough. When I was a resident in Tamil Nadu years ago, they started the Safer Pregnancy in Tamil Nadu from Vision to Reality. It started in Velo first, and they have a birth companion in labor. It started as an RCH program in the Chennai Corporation, and they shifted to all the institutions. It is still in progress there. So this is something that we really need to think of. Do we need a cadre of midwives? I am sure 90% of us will say no. I will say yes. You need somebody who will sit with them, be with them, who will probably also deliver them. Delivering we should not over-medicalize our pregnancies and our labors by interfering too early, interfering too much, doing too many ARMs, finding out things that there may not be, and eventually landing up in a cesarean section. So this is something that the government is also looking at slowly. It's not going to come anytime now, but where I work, I would welcome a few midwives. I hardly have any doctors, so I would welcome somebody who would help me. This companion that I'm talking about is a low-cost initiative. It has numerous benefits. It shortens the duration of labor. It lessens, and this is what we have seen. I'm not talking about 10,000 deliveries. I'm talking about, as we stand today, 102 deliveries that we've done since April. Shorter duration of labor, less pain medication, decreased rates of cesarean, decreased need for oxytocin on the whole, nurture satisfaction, much better bonding, very good breastfeeding rates. I'm learning economics as well, which is a subject of supply versus demand. So is there a supply of doctors for us to do on-demand cesarean sections? Yes, there's one round the corner everywhere. Is there another adequate number of paramedics or midwives to offer one-to-one care in childbirth? No. We don't have nurses to offer one-to-one. We don't have midwives to offer one-to-one. Neither can we do it. So I think it's time to sit down and think, do we need some help from them? And what is the economics behind the rising cesarean section rates? We don't have adequate staff. Very many of us don't have round-the-clock anesthesia services, so you'd rather finish the cesarean section when the anesthetist is there. You make vaginal deliveries more costlier than cesarean sections, or at least the same amount, you may reach somewhere. Change the attitude of the public. So when you're called for talks on AIR and Doordarshan, talk about decreasing cesarean section rates. Change the attitude of the public. Dispel myths that cesarean sections are safer, because they are not. When you come to the crux of making a woman comfortable in labor, actually when Sir had asked me, I said, what should I say, I was full of enthusiasm. I said, can I do making labor safe as well as comfortable? Then I realized if I was to do safe as well, I would be unsafe where time is concerned, so I've cut that off. But when you think of making her comfortable, the biggest thing that she's worried about is pain. So if you look at that, no, not working. Yeah, from the IV sedation to the breathing exercises, to the massages, to the inhalational analgesics, to the epidurals, which is supposedly the gold standard, to the transcutaneous electrical nerve stimulation, we realize that pain or the lack of it is the key to comfort. Or the woman should know that there is somebody to help her, there is pain, I'm going to tackle it. So deal with the pain before it starts. So antenatally, she has to deal with it and you have to help her deal with it. See, we cauterize the cervix under local. We burn the cervix, but it is extremely sensitive to pressure by the descending head and by dilatation. It is a painful process. So empty the bladder, the presenting part will press on the bladder, encourage her to go walk and pass urine in the toilet. Don't give her the bedpan. And rectal pressure is also a source of discomfort. So what is the crux is that difference among people isn't in their perception of pain, but in their ability and their motivation to withstand it. So how do we alleviate that pain? Change in posture. We have about 10 beds in the first stage, and at one point in time, only 4 are occupied. It's a long labor room, so I encourage them to walk. I don't have birthing bars or sophisticated equipment. I just have a bed. So the woman is encouraged to walk with her mother. Every time she has a contraction, she stops at any particular bed and holds on to the handle of the bed, breathes in, leans forward, and we even teach her the breathing exercises when she comes for antenatal classes. I have found that the heads that don't descend, you make them walk, you make them sit. I'm not saying walking is possible for all. When they have oxytocins, it's difficult. So make them sit for some time, make them lie down for some time, make them walk for some. Disconnect the Pitocin for an hour. Nothing is going to happen. They'll deliver. Counter pressure, massage, electrical nerve stimulation, we don't have it. Attention focusing devices. Relaxation, slowed. When we teach them breathing, I'm saying this because very many of them, at least I never knew it until about 5 years ago, that when you suppose you're at a consultation with a respiratory physician and he tells you to breathe in, you automatically suck your stomach in and breathe. But what the laboring woman is to do is to blow her stomach out as she breathes in. That helps. That itself is a pushing device for the baby. So you need attention focusing devices, slowed breathing, music if you have it, exercise and be active, don't take bed rest in pregnancy. This is something that I believe. Given freedom of choice, we don't give them that freedom, but if they're given that freedom, very few women in any part of the world would like to lie down in labor. And I, as an assistant professor, and I think a little bit into my associate professor days also in SAT, they would adopt all kinds of positions and we would call the bystanders, look how your daughter is behaving in labor. She's not listening to us. She's not sitting down. If something happens to the baby, I'm not responsible. Now I realize that's just her way of tackling her pain, and I think we should allow her to do it. We need to change the way we think. Then she will be more comfortable. Lying flat on the back is no good at all. The upright position shortens and eases labor, 36% shorter for primies and 25% for multis. So walking around helps. The contractions become stronger, they become regular, they become more frequent. It automatically corrects the angle, especially you have a woman with an obese abdomen, the uterus is lying to one side and she is to one side, make her walk around. It corrects the angle between the baby's axis and that of the maternal spine. Gravity helps the baby in making its way down. The uterus meets least resistance when the patient is standing and leaning slightly forward. So you encourage whatever position she likes because no one size fits all. Sitting, kneeling. She doesn't have to kneel on the floor. She can kneel on the bed, but encourage it. Don't strap her down with 2 IV lines all the time. Half kneel, half squat. Sit upright, sit on a chair. We can give her a chair. She can sit on the chair, straddle the chair. She may feel a bit more comfortable. If she's lying down, let's say she got a fetal distress, she had a mild amount of bleeding, she's a high-risk patient, the head must be up. Patient must be on her side. Something like the left lateral Sims position, one leg can be flexed at the hip and at the knee. I think more than the ambience, it's the attitude. Soothing environment, we may not always be able to provide it. The birth setting must feel safe. And as an obstetrician, I think I am lucky because I have a terrific team. We're a very small team. There are hardly any in our team, but they're excellent. They want the women to deliver. So choose your team carefully and let your patients be well informed. The world, most of us are talking about natural labor. Nobody wants epidurals, nobody wants analgesia. They want to do it the right way. So tell them that they can be offered counter pressure, massages on the back, breathing exercises, water, I'll come to it, birthing aids, the ball, the birthing bars, vocalization. Another thing, when they scream in labor, we say, every time you scream, the baby is not going to get oxygen. It's not true. She can scream, but tell her that others may get a little disturbed, so kind of tone down your volume, but do whatever you want, as long as you deliver. Water births. I have no experience with this. Supposedly decreases the need for analgesia, including epidurals. No difference in type of delivery, APGARs, infections, perineal tears, but the duration of the first stage is less. I guess they feel a little more buoyant and a little bit more comfortable when they're in water. But remember, when she is in water, do not give her narcotics because she may not be in her senses. But there are a lot of checks. Before we go in for all this, we need to check if you're able to sustain all these things. The caregiver must be very well trained. The quality of the water, the temperature of the water should never exceed 37. Protocols for change of water are to be in place. When they started the water births, I was actually a bit skeptical. I thought, putting them in water, won't they turn out to be prunes? Just dipping them for so long. But as I have read, the Royal College of Midwives have got a lot of work on this. They supposedly fare very well. Now I'll come very briefly to pain relief, just to tell you that you do not need to know the doses of the epidurals and everything, because that's the job of the anesthetist. Let's stick to ours. But we need to know what kind of women would require an epidural. So right from the 1800s, ether and chloroform started, and Moyer talked about the delivery of an infant into the arms of a conscious and pain-free mother as the most exciting and rewarding moments in medicine, and I think I agree with him totally. Etherization of labor, young Simpson started it. In 1953, John Snow administered chloroform to Queen Victoria, as we all know, during the birth of her 8th child. Would you question it today? You would tell her, 8th child, you just drop it off. But it was Queen Victoria, and they gave her chloroform. In the 1950s, neuraxial analgesia was started. Now, when you look at pain relief, there are a whole lot of non-pharmacological methods that we can use. Touch, massage, continuous support, TENS, water bath, sterile water, acupuncture, hypnosis. None of these have very firm conclusions to support it totally. Parenteral narcotics, you have a whole lot. Pethidine really is not so good. You need naloxone for any of these if the baby is depressed. But pethidine really doesn't cause too much of pain relief. Ketamine can cause dissociative analgesia. It may not be very good. Fentanyl is good, not very easily available. Tramadol, we all use it, safe. Buterphenol, remifentanil, not very easily available, but quite good. Inhalational agents, Entonox, some of us are using it, 50-50, nitrous and oxygen. But really, even it provides a certain degree of pain relief, more so that the patient is controlling her own administration of the Entonox. You can use other agents as well. Regional analgesia, if she's really worried about pain, it is regional analgesia, it is an epidural. The recent advances are, you can use needle on needle, combined spinal and epidural, even in labor. Continuous spinal using microcatheters, ambulatory epidurals, a whole lot of new pharmacological advances, technological advances as well. For us, as an obstetrician, we need to know some things. When do you need to, suppose she wants the epidural, when do you need to site the epidural? I was in Fernandez 20 years ago, working as a junior consultant, and then epidurals were given at 4 centimeters at the beginning of the active phase. But no longer true. So it is given maternal request. When she feels she needs it, you give it. An early epidural is not going to do any harm. And the neuraxial analgesia prolongs the duration of labor by an hour or so. Occipito-posteriors, oxytocin augmentation, instrumental deliveries are more with epidurals. There's no statistically significant risk for cesarean section. But remember, when the basic philosophy is simple. You want the woman to be conscious, you want her to be alert, you want her to push. You may also want her to be mobile, a minute. So it's better to decrease the dose of the local anesthetic agent you're using and team it with something like fentanyl. So a low dose, low volume epidural is probably will negate all these problems. There is a comprehensive obstetric mobile epidural trial where they found that when they gave the traditional epidural, only 35% of them delivered, but it upped when they used the low dose protocols. This madam had said it, PKS madam had said it, there's a people study that is pushing early or pushing late with epidurals. And I think this is important whether the woman has an epidural or not. She said so clearly that after full dilatation, it's basically a question of an extension of the first stage where the head just descends from 0 to a little down. Just because she is fully dilated, don't make her push. When the head is on the perineum, deliver her. Do you need to withhold the epidural top up in the second stage? No. Inadequate pain relief will be a problem, and there is no decrease in operative deliveries. This is my last slide. If they're worried, you tell them that there are no problems with backaches in the long run. There's no hindrance with breastfeeding. There may be a small amount of maternal pyrexia. You don't need to really investigate it too much. And post-dural puncture headaches are much less now that we're using very fine needles. Thank you so much.
Just a couple of questions for 5 minutes before we break for lunch. Dr. Serena, what is the mode of delivery? How long can we prolong pregnancy twin gestation with single fetal demise?
Okay. Now, as soon as you hear a single fetal demise, the first thing that you got to check is the chorionicity. If it's a dichorionic twin, you really don't have to bother much. Okay? The second thing you don't have to bother is when it is in the first half of pregnancy. Early pregnancy, a fetal demise really doesn't matter much. The next thing that you do is you find out if it is a monochorionic, why did the baby die? Okay? And then you must remember that you can carry on in a monochorionic until the time of maturity. So around 34 weeks, and then you can deliver. Now, the problems which a babe can have, the earlier concept is gone. Now, the present concept is that once a baby is dead, the live fetus, there is a shunt of blood from the live to the dead fetus. So the one who suffers is the live fetus. So, and what can really happen is an acute shunting of blood, and so the baby can have neuronal problems, and so you can, if you're going to prolong the pregnancy, after about 2 weeks, max 3 weeks, you can do an MRI, so fetal MRI, and then you might be able to know the status of the white matter of the baby. So the best thing is dichorionic liver, early pregnancy liver. Monochorionic, you can wait till 34 weeks and deliver the patient. Otherwise, try to find out why the baby died. Okay, so it's a TTTS or TRAP or whatever. And then, if at all you want to continue more than 2 to 3 weeks, you can do a fetal MRI.
And one more additional question, what would be your surveillance of the live fetus? How will it be?
Yeah, that's exactly what I told you. Take it as far as 34 weeks and then you can deliver the baby. The possibility of a DIC is all more theoretical than prior. So you really find problem with the live baby. So there are 2 important organs you should monitor. One is the brain of the baby, and next you can go for acute cortical necrosis also.
Role of steroids in twin gestation.
Yeah, just like any other. I thought he gave some excellent messages. I should say, sir, that your talk was an excellent talk, very emphatic messages. So it's the same, goes for 24, 34 weeks. Within the time the baby delivers, then you will have to give steroids.
To Dr. Shamla Dev, madam, what would be your protocol of choice for a full cervical dilatation, and what is your experience?
What is a protocol for choice for full cervical dilatation?
You mentioned various other techniques, push, pull, all these techniques, and what would be your choice?
Because only one I have done Patworthens because I have to do it because the shoulder came out when I put the incision. Otherwise, I go for reverse breech extraction. I find it very easy to do it because we are not doing any damage. I personally prefer reverse breech extraction. As I told you, when the shoulder comes out, don't try to push back the shoulder. You know where the back of the baby is now. So go to the opposite side, gently push your hand upside, you will get the foot. So give traction. When you are giving traction, don't give excessive traction to one foot. You will produce damage. Get both feet together, and then you bring it and give parallel traction. If you still find difficult, you can just make an inverted C-shaped incision, or you can make it a J. Actually, I have never put an inverted T-shaped or J-shaped incision. I could manage with the transverse incision. I personally prefer reverse breech extraction.
Madam, can I just add on to that? I will say, first of all, take a deep breath. Don't get anxious, okay? And then best thing which we do in our institution is we allow somebody to push from below. But don't push too much that it goes above the level of your incision. Then it becomes either a floating head or a transverse line, okay? So you push just enough so that you get a grip. Put your hand there, take your time, and then slowly lift up. Don't do it in a hurry. That's when you get extension of the wound. And then as soon as she's pushed enough for you to grip the baby, then just lever it out, slowly. The word slow is very important. But you can use any technique.
Whatever technique you use whichever you are used to. What you are familiar with, you think that you are confident to do it. Be calm, quiet. Don't be in an upset, don't get upset, because the whole team will get upset when the team leader is upset. So think, be quiet, calm, quiet, and you do, nothing will happen. You can, whatever you are used to do, you do.
And Dr. Sangeeta, your talk on making labor safe, there is no questions for you, but I think you did a wonderful job. So I'd like to thank all the three presenters. And before we break for lunch, memento as part of our appreciation.
As a token of love and appreciation, we'd like to present the speakers with a memento. Dr. Serena Gilvas. Thank you, ma'am. Dr. P.K. Shamala Devi, madam. And Dr. Sangeeta Menon, madam, for that very interesting.
Can I start? Any more panelists to come? There are 2 more chairs. We can start. Okay, we have 1 hour, 15 minutes. 1 hour. Okay, fine. So, welcome, panelists. I think all the cases that I've got are very, very practical and what we have faced in our hospital and in most hospitals, I'm sure. Without wasting much time, we'll just go through the definition for the benefit of the audience. What is risk management? It is a systematic identification, assessment, and evaluation of risk. If done well, it is supposed to improve the quality of our care and develop safety systems. It can be reactive, that is when you're analyzing after the incident has occurred, proactive if you anticipate it, or preventive if you know that it's going to happen, take steps to avoid it altogether. So it mainly exists to improve quality of care, and as our previous speakers in the morning have mentioned, it is not to blame anyone. Having said that, many people feel threatened when we do this, but it is up to us to make it as friendly as possible with learning as the main objective. And it is essential to raise awareness at all levels, not just doctors, our paramedical staff, our supporting staff and auxiliary staff. Everybody plays a role in terms of emergencies because it is a multidisciplinary team involvement that helps us get through the emergencies that we come across in obstetrics. So what it is not primarily to avoid or mitigate claims, not simply reporting alone and leaving at that, and it is not just for admin staff to look into it. All of us play a role. And what are the basic questions addressed? What could go wrong? That is risk identification. What are the chances of going wrong and what would be the impact to the patient? That is risk analysis. And what can we do to minimize the chance of this happening again, which is the main thing? And what can we learn from this? So these are the aims that we go through when we analyze an incident. We'll skip all these. There are triggers in literature that you can use. You have to create an environment in your labor ward and in your obs-gynae departments for people to report, to identify these triggers and report so that learning lessons can be learned. Similarly, triggers in gynecology. So we analyze in our hospital, we have a CRM committee, Clinical Risk Management Committee, and on a monthly basis, we encourage staff to put slips as to whichever case they think the management protocol was breached, and then we sit down and analyze and present the cases. We categorize them as management issues, admin issues, medication errors, and so on. And then learning lessons will be learned. Every month dedicated, we have a CRM session, both for general obstetrics and gynecology, and from a fetal medicine perspective, especially if there are scan mismatches. So what we all don't want to see is cases like this. As you can see there, there's clear intrapartum mismanagement with the baby ending up in cerebral palsy. This is a nightmare that we don't want to do. So I will begin. Why do doctors get sued? So can I start from that end, Mr. Steer?
The commonest reason, in my experience, is when there are clear national and international guidelines with which the doctors involved are either unfamiliar or where they decline to follow them. And that's not to say that you have to follow a guideline.
Can we have another mic?
Yeah, it's not that you have to follow a guideline, but if you decide to deviate from it, you have to give very good, clear and defensible reasons why you don't. And so in my experience, it's not just because there's a poor outcome, it's because firstly, the doctors are not following accepted and established guidelines, and secondly, it can be that they get sued because of poor communication. That's the other common failing, is that the doctors are not communicating very clearly with the family about what the issues are. Now, if it's just a failure of communication, it's unlikely that a case against the doctor would succeed if they followed the guidelines. But nonetheless, having to go to court and defend yourself is very stressful. So it's best to try and avoid that, if possible, firstly.
Serena, you want to add anything to that?
No, I fully agree with him. I think when you've got a problem situation in your hands, see whether your setup can tackle the problem. And if you're required to refer early, not very late. That is very important. See, for example, I'm telling you in a placenta percreta. When you, from the beginning itself, you know that there's going to be a problem. So then you refer off to a center early, one. Second is, as he rightly said, develop a good rapport with the patient. When you've got a problem case, meet the bystanders more often. It is not the time that you should avoid them. Meet them more often. Explain to them on a 1:1. And I always feel you have to tell them. You don't have to tell them everything. Tell them what they understand. Tell them little by little. The third scenario, which I feel is when the case is very bad, what we do nowadays is we allow them to peep into the labor room. Supposing we have had a sudden, for a low-risk patient, a postpartum hemorrhage, I allow them to peep in just to tell them that we are doing everything. The patient should always understand that we have put our best foot forward. I always tell them we'll do our best, rest we leave it to God. And if at any time they want to take the patient elsewhere, do not say no to them, you leave it to them. See, this is what I've got to tell you. These are the facilities available in our institution. And then you don't tell them to take. If then they volunteer to take the patient, allow them to go. Don't, for heaven's sake, hold on to a patient when you feel that, there are problems which can arise in the same patient.
Thank you, Serena. Just to sum up what both of you said, most often they want accountability. The patient would want to blame somebody or want an explanation why it occurred only to her. So she needs an explanation. I think sometimes honesty pays off. It's always best to sit down and tell, look, even if we have goofed up, this is where we went wrong, and this is where we tried to rectify, and this is as it happened, and document in the notes. Then the patient will also have some concern. Oh, if they've done this to me, are they going to do it to how many other patients? So therefore, they want to know that we are going to learn from it and put a system in place to avoid it again. And lastly, maybe they also want compensation.
I would just add, you said sometimes honesty pays off.
Always.
Always.
Yes.
And just to warn people that if, for example, you're not completely honest with the patient and you're discovered, it could be an error of judgment. But if you then obfuscate or distort the truth or you try and cover things up, in the UK, that can end up finishing your career.
Yes.
Because an error of judgment in a professional person is acceptable, But being untruthful is not, and the General Medical Council will simply take away your license to practice. So it's not just for the patient's and the family's sake that you must be honest. Actually, honesty is your best defense as well.
True. I agree. On that note, why do you think doctors find it very uncomfortable to be honest, especially if there is a complication or there's some error on their part? Why?
I think it's because initially, when you're learning, you're unsure about everything. And then when you become reasonably experienced, what I call senior registrar level, they've developed a way of dealing with most things, and they tend to think that's the only way you do it. And when someone questions what they're doing, they feel threatened and uncomfortable. And the strange paradox is that the older I got and the more knowledgeable I got, the easier it was for me to accept that I didn't always get it right or know the answers. And actually helping younger people to come to that ability sooner is an important part of mentorship. Being able to accept that you made a mistake or you gave somebody inappropriate advice or whatever is important not just for the patient, but it's also important for your learning.
Now, on that note, can I ask Mr. Cunningham? I want to be honest with the patient, but the patient had a complication occurred elsewhere or done by my colleague. Now, I am very worried. I don't want to put her in front of the patient as, especially in our Indian scenario. I'll give you an example. A patient has come to us from another hospital. We have, with sepsis, fever, following an operation, and we found a swab. Now, what is, my duty is to be honest and tell. But at the same time, I'm worried they will go and create nuisance in front of that private practitioner. Now, this sometimes, what am I supposed to do?
Okay, I think that particular scenario is relatively easy, really, because you just have to be honest about what you found. I think assigning liability isn't your role as a doctor, really. You know, you can't say, there's obviously the practitioner, what an idiot, but I think you're presenting the evidence of what you found. I think the difficulty comes when people ask, well, what would be a normal standard of practice? So in fetal medicine, the scenario we frequently come up against is newborn babies who have abnormalities that weren't seen on ultrasound scan and go off to a different unit, and then we hear back from angry parents saying the pediatrician said this should have been found and all this, and you know, why didn't you see it? And we're looking at a complaint. I think we always take those with a pinch of salt. You know, we don't take those at face value, really. We don't believe that doctors would actually say that, but at the same time, you know, we think it's important to actually communicate with the unit as well and just say, this is what's been said to us. Would you have any comment? I think you have to, if you are going to make a statement against somebody, I think you probably have to involve them in the discussion, really. Yeah.
Yes, yes.
Can I add to that? I'm not sure that I would want to get into a discussion with the other consultants. There is a practical solution which I have used, and that is consultant A has done something you think actually was outside the guidelines and was inappropriate. You explain to the patient exactly what you did, what your conclusions were, and what the guidelines are. And then what I say to them is, I do not wish to get involved in advising you because you're now my patient and there's a conflict of interest. I will recommend to you a number of senior colleagues, not with any financial or other communication, but genuinely independent, or you can go to our Royal College and go to an independent consultant who can look at what the first consultant did and what I did, and then give you independent, unbiased advice. And you facilitate that. That takes the problem away from your environment and gives it to someone else to deal with, and they're in a much better position to give the person unbiased and independent advice.
But Commissioner, can I differ in this? I do not agree with both. When we have a situation in which I've detected a mop inside the abdomen, you know what I do? I pick it up and just drop it. Not even my assistant will know that I have done it, because the scenario in our place is not as congenial as it would have been there. Don't you think you all agree with me? How many of you all agree with me? Because it so happens here, they first hit you, then only they apologize. So instead of getting that, even it happened about 3 weeks back. There was a mop after imagine it was a large gauze piece which was kept after a vaginal hysterectomy. And you know, I felt something. I took her to the labor room. I put her legs up and I just pulled it out. The one who assisted me asked me, ma'am, what's it? I said, I'll tell you later. Because when the situation is very hot, If you are to go and tell something, the situation in our country is very different. And secondly, I cannot be as open to the patient as they have been. I call it a white lie. You know what I mean? I put my problems across, but I put it in a very refined fashion so that they do not think that my subordinate has made a mistake. I put it across, it has been done that way, but probably this is a better way. You understand what I mean? I put it in a more refined way. I will never ever let down my juniors or tell them that, you know, they have not followed the guidelines, but I'm going to follow. That cannot be done in our country because the scenario is very different. You all agree with me? Yes.
You are letting down your juniors, because in the long run, this will lead to the disrepute and the abolishment of any trust in the medical profession. And if you think that's what your juniors want to see in the future, I'm afraid I think that's wrong.
But
And
Dr. Steer, I will correct him in the private.
I couldn't possibly agree with the suggestion that you've made. I think actually it's appalling, and I'm very sad that I've heard
Let's
it.
agree to disagree on this one, because the cultures are different, the environment is different, but hopefully we will do what is right.
Honesty and truth are universal.
Yes,
I'm sorry.
yes, I agree. So we will now move on to the first case. Here is a 22-year-old, I don't know if you're able to see it. The audience are not able to see. 22-year-old nulliparous lady with a BMI of 38, no other risk factors. She was induced at 41 weeks. ARM revealed meconium stain liquor. There was some documentation as to difficulty in obtaining CTG with lots of areas showing loss of contact. What would you do? Madam Shamala?
Ideally, it is continuous CTG to be monitored this patient. If there is no, CTG is not working, all this, I think if you can auscultate the patient and see if there is any fetal heart changes. After every contraction, you auscultate the fetal heart with whatever measures you have. If there is no deceleration, you can continue with pregnancy, continue with monitoring. If she is progressing, you can leave for vaginal delivery. There's no need for cesarean.
Yes. I want to make a point that just looking at meconium, and with some CTG concerns, mind you, if there's loss of contact, what should be done? I will go through that. There are people doing cesarean sections. But the guidelines say that if there is meconium, with a good CTG, we can wait, but continuous surveillance is required and good quality CTG. So it is, seeing meconium itself is not an indication for cesarean section on its own. Okay, so we agree on that, what Madam said. Now, in this particular case, the duty doctor was called to review the CTG, and multiple times the doctor has seen, each time writing that observe, continue to observe. There is slow progress recorded in the first stage. Then she advised oxytocin, just like Mr. Steer has mentioned this morning. After some time, a vaginal examination revealed that she was 8 centimeters dilated. So at which point she called the doctor. The doctor has written reduced variability, late decelerations, but watch for some time because she's 8 centimeters and she might become fully dilated. Do you agree with this doctor's plan, Dr. Preeti? There is meconium. She's 8 centimeters. CTG concerns. Now reduced variability with late decelerations. What would your first advice be?
The CTG is after proper contact and everything.
Yes.
Okay. I think it might lead to I mean, what's the level of the head?
She's only 8 centimeters.
Is dilated.
Yes. Forget the head level, but she's not fully dilated again.
Then I think a section would be more advisable.
If there is a facility to do scalp lactate, maybe, scalp pH. Yes. So that can, because she's so close to full dilatation, you want to be 100% sure you're doing right thing by the patient. Justify your decision if possible. I'm not saying do scalp lactate if there is a big bradycardia and, you know, life-threatening. So that is not the case to do. But in this case, maybe a scalp lactate. Anyway, so the doctor decided to observe for 30 minutes. The decelerations persisted, and then she decides to, for an emergency cesarean section. So what do you think the baby will come out as, Mr. Cunningham?
Oh, I think we were discussing this scenario, a similar scenario over lunch. I think there's a relatively strong possibility of meconium aspiration. Obviously, in the presence of persistent decelerations, we've never really had a reassuring CTG?
Yes.
It doesn't sound like it from your history.
There are bits in between where we can't interpret.
But has it ever been reassuring?
There are some periods where variability was good, and then again the variability reduces and there are decelerations. I didn't put the CTG because to save time, actually.
Yeah, okay. I mean, I think in this scenario you presented...
You can expect a bad outcome.
Yeah, I think you can expect a reduced...
You may get away as well. So what happened in this case? Live female baby, 3.5 kilos with Apgars of 3 at 1 minute and 6 at 5 minutes. But the pH is okay. As I already said, don't go by one parameter alone. So this baby had low Apgars with all risk factors. Even though the pH is above the 7.05 cutoff, this baby still needs observation. So guess what happened to this baby? Baby had seizures, discharged after 5 days. At subsequent visits, the mother is concerned that the reflexes are not developing, and finally it evolves as a cerebral palsy case.
Can I just comment about some data here?
Sure.
If the CTG tracing is normal and reassuring, the presence of meconium is essentially just an indication of maturity. So only about 5% of babies before 37 weeks will pass meconium, but that will go up substantially to 30% at 42 weeks in a white European, and in black Africans it's 60%, due entirely to increased maturity. If the CTG is normal, cord gases, baby's condition at birth will be normal, so the meconium is not adverse. Now, if you have an abnormal CTG, the likelihood of poor condition at birth will go up from about 2 or 3% to perhaps 20%. But if you have an abnormal CTG and meconium, that combination increases the risk of a poor outcome to 60%.
Yes.
So as far as I'm concerned, if there is meconium and the CTG becomes abnormal, that's equivalent in terms of an indication for delivery as, for example, having a low pH, because the implications in terms of neonatal condition are similar in proportion. And personally, I would regard meconium as a relative contraindication to giving oxytocin, because if you change a normal CTG into an abnormal one by hyperstimulation, you've immediately greatly increased the risk of meconium aspiration to that baby. And medico-legally in the UK, that would not be defensible. So in my advice has always been, and it's in our book and all that sort of stuff, is that if you have meconium, you should observe very closely. If the CTG then becomes pathological, as opposed to just suspicious, but if it becomes pathological, in my opinion, that's an indication for delivery. Because if you wait until the baby is acidotic as well, the chance of the baby being in poor condition is going to be 90%.
Sure.
And do you really want to wait until it's 90% before you deliver? 60% seems to be, to me, to be a high enough risk. And as you've seen, unfortunately, this sort of thing can happen. And you made the point very importantly that we actually published a paper in 1986 in the British Journal which showed that fewer than half the babies compromised at birth needing active resuscitation actually had a low pH. There are multiple reasons why babies are in poor condition, and to get the idea that the majority of cases are because of acidosis or indeed even a hypoxia. There's infection, there's pyrexia, there's mechanical problems, etc. And I think we need to consider all of those in context.
Sure.
Commissioner, just one sentence. See, looking at that CTG, if you've got a meconium and a normal CTG, you can wait. But if in that CTG, if you've got a late deceleration plus poor variability, it already tells you that the baby is not just hypoxic, but is also acidotic. So that is an indication probably we should not have waited. So poor variability with late deceleration is a sign that the baby is acidotic in utero. Immediately you should have terminated the pregnancy. Because 8 centimeters, 1 hour, 2 hour, and probably another 2 hours, 4 more hours max, right? Will that baby withstand that much of acidosis? That's why the baby was, you know.
Sure. So, obviously, litigation followed. And what would the allegations be, Mr. Cunningham? This patient has a reason to sue us? Yes. For what?
I think taking it in its entirety would be, in terms of risk assessment, hasn't been correctly carried out on the initial phase. I think then that's coloured what's happened later on, really. The causation, is going to be difficult to prove with the normal cord gases. But I think, what would be your opinion is whether or not they've reacted to the CTG changes which have been there in a timely fashion.
Sure. So this lady, allegations were fetal heart rate recordings were inadequate with loss of contacts, significant abnormalities not recognized, that is the late decels and reduced variability, oxytocin inappropriate in presence of CTG changes, and the abnormalities needed earlier intervention, as Serena said, and decision was delayed inappropriately. And having made the decision, the delivery time, I'm not sure if people are aware of the time limits before which we should get a baby out. There are 4 grades of delivery. Grade 1 is when it is life-threatening to the baby or mother, as in a severe prolonged bradycardia, massive abruption, or cord prolapse. You should aim to get the baby out. 15 minutes used to be the ideal in the unit where I worked, maybe 20 minutes in some units. But if there is a trace like this, which is not immediately life-threatening but needed delivery out, half an hour would be the limit before which the baby should be out. So this, in this case, the decision delivery interval was more than that. So these were all the allegations. Now, whenever people litigate, I'm sure Mr. Steer can tell me better, we should prove breach of duty and establish a link, that is causation. Only then the claim will be successful. So on what will they make these decisions on what we write, what we document, as having counseled the patient? If we don't, what is not written is deemed as not done. So we must make time to document. They should be clear and concise. And breach of duties, if we have deviated from the just deviation is not breach, as Mr. Steer said. If we want to differ, you have to justify your decision and write it in the notes why you chose to differ from the protocol. Obstetric cases frequently involve CTGs, and we must always, in hindsight, retrospectively, not over-interpret these changes. So therefore, they call these expert witnesses who are neutral people, who are not involved in the cases, with fresh eye, because hindsight is always, everything looks different. So we should give them that benefit of doubt, and it's helpful to refer to published guidelines like NICE guidelines when we are interpreting CTG, so that the subjectivity element will be as little as possible. And it's important to obtain good quality trace, which we didn't in this case. A scalp electrode can be used in high BMI patients where the abdominal transducer is not picking up. So scalp electrode is very easy. It is available in Fernandez. We do use, so I suggest all of you practicing obstetrics use these for high BMI patients, maybe in twins, so that you know one is first twin and one is another twin. So there are places where you can use this. And the plan should be reviewed every time and re-recorded. Fetal blood sampling if further, but as Serena said, I agree, it depends. Whether to do lactate or whether to do direct cesarean will depend on the CTG at that point, how bad it is. And oxytocin should be reduced or stopped if fetal heart rate is abnormal. On balance of probabilities, timely FBS would have saved some time in this patient because they were segments of trace where variability was good. And there was no justification for prolonged delivery interval. And so in this case, there's clear breach of duty, so it was not contested, and it was agreed that there was substandard care, and on this aspect, it was settled. This is a scalp electrode for people who want to know. It is very easy, it is available, and easy to put. If time permits, I will show a video later on. And this is the scalp fetal blood sampling kit that we use in Fernandez. We devised the amnioscope, and the lactate meter is available just like how you check your blood sugar, BM sticks. You have a lactate stick. So you draw a drop of blood from the baby's scalp using this blade and this scope, and then it will put it in that machine. It will give you, I will show the videos later on. It will give you a value, and we take 4.8 as a cutoff, above which we opt out and do a cesarean section. Now, causation. Assume that the intrapartum care was substandard. Do you think we can link it to the causation in this case, Mr. Steer, since you have been an expert witness in many cases?
Yes, if you say it's not linked, then you have to give a plausible reason why the child has this abnormality.
Yes.
So it either has to be shown to be a developmental abnormality, in which case you may need to do MRI scanning and so on and so forth, or you have to show that there was some other incident during the pregnancy which may have given rise to this sort of damage. If, in a civil case, the standard of proof is on the balance of probability, which means 51% likely. It's not a criminal case where you have to show beyond any reasonable doubt.
Yes.
So on the balance of probability, if you present a judge with no evidence at all of any other damaging insult, plus a situation here where there was lots of evidence of something that could have caused damage, he's going to say, on the balance of probability, I'm going to explain, I'm going to assume that that was the cause. And the example I always give is that if you see somebody knocked down in the road with injuries and you see a bus moving away down the road, but there's nobody else about, it's reasonable to assume it was the bus that knocked the person down. You didn't actually have to see it with your own eyes. It's a question of what is likely on the balance of probability. So I think it's extremely likely that the judgment would be in favor of the plaintiff.
So we went through these criteria this morning to link it, and Figo also said pretty much the same thing. So what happened in this case? After multiple opinions on balance of probabilities, it was suggested that the damaging insult, it should have happened in the 40 minutes prior to delivery. So they couldn't prove that beyond doubt. And despite the criticisms of the attending staff that there was a clear breach of duty, the case was defended on the grounds of causation.
Even in very clear cases, plaintiffs will often settle for 80% of the damages,
yes,
because judges are human and
yes,
they may sometimes make decisions which are
not
consistent with what colleagues would say. Sure. The other point I think needs to be emphasized in this case is that meconium aspiration is not simply related to acidosis. In fact, the majority of cases with acidosis, even when there's meconium, don't aspirate. The major cause is actually an acute insult which stimulates the gasping reflex. So we all know going into a cold wind and we get the gasping reflex. Acute hypoxia can do that, so can trauma. So a very traumatic forceps delivery can cause a baby to aspirate with normal cord gases. So we mustn't fall into the trap of thinking we have to wait till acidosis before that's a risk. And in fact, I would say that if the baby is already acidotic, you have waited too long because the risk was already very high. That's my understanding of the literature anyway.
Sure. So in all your units, audit your own PFCs. Status of the baby correlate with ABGAs, start doing cord ABGs, which will protect you sometimes. As in this case, the pH was normal, that was the only positive thing. And audit your own intervention rates. Are you doing the intervention for the right reason? And audit your adverse outcomes. Okay, so we will move on quickly to case number 2. This is Mrs. S, who's 32-year-old, second gravida. She had, again, a very, very familiar scenario. 3.7 kilo baby, unremarkable second pregnancy. She was also induced at 41 weeks. First stage, there was delay and oxytocin was used. She then reached full dilatation, and after 1.5 hours of full dilatation, the head was delivered. There was turtle sign. So there was shoulder dystocia at her delivery. Help was called. Maneuvers, macrobot, suprapubic episiotomy. It is written in the notes, moderate traction applied and delivered a 4.5 kilo baby. Erb's palsy was detected, and despite physiotherapy, significant injury persisted. So, shall I ask Dr. Preeti, do you think we have done the right management for this patient, or would you have done anything different? Second gravida, previous 3.7 kilo baby. This time, we all know scans in the third trimester are not very accurate.
Very accurate, but
would you have done anything different?
The gestational age for
41
induction
weeks.
is 41 weeks. That is probably the cause for the shoulder dystocia.
But what would you do? Would you do a direct cesarean, and if so, why? Mr. Cunningham.
If the dates are correct, why do we wait till 41 weeks?
That is a recommendation. Mr. Cunningham?
I just wanted to ask, I mean, when you started the oxytocin, what has been the assessment really? Because that would be key really. where are we? What does the baby
She
feel
was
like?
progressing slowly. She got to in 4 hours time, 3 hours time. We do vaginal examinations every 3 hours in a multigravida. So she reached from 4 to 5. So suboptimal progress, and not the 1 centimeter per hour dilatation.
So you wouldn't really, you wouldn't really expect to have to start oxytocin in a multiparous lady?
Probably we needn't have. She would have eventually reached full dilatation. I don't know, but that was done in this case.
I think my point is that assessment is probably going to be crucial in
No, suppose I tell you between 2 VAs she is 4 and 4.
Yeah.
What would you do?
But I think obviously if labour is not completely started, we would think about a short course of oxytocin to see if it's going to improve progress. I think your question is really whether or not the shoulder dystocia could have been predicted.
Yes.
But the other half of the question is whether or not when it occurred, has the response been appropriate and timely and also well documented as well? I don't think it could have been predicted from what you're telling me.
In this case, yes, it was not predicted. It caught them unawares. They thought...
in that context as well, it's very difficult to actually consent to the patient because you can't have predicted it.
Yes.
So now we're sort of looking at whether or not the response of the team was timely and whether or not the Erb's palsy has been caused as a complication or by injudicious care, really.
Moderate traction is the point.
Well,
who can judge?
Yeah. Can I just, because I have actually defended 2 cases of Erb's palsy and been involved in a lot more, and on one occasion spent 2 weeks in court, and we actually successfully defended a doctor from this part of the world who flew all the way back to the UK to defend her management. And the first thing I would say is there's nothing there in that history that would convey a very strong likelihood of shoulder dystocia, and it's accepted that most shoulder dystocia is unpredictable. So you can't blame someone for not expecting it to happen. But where you can blame them for is if they don't carry out the correct maneuvers. Now, what then needs to be recorded is as follows. Firstly, you need to document the traction, not just in terms of how strong the traction is, and just saying moderate traction is not really enough. You have to say, I applied traction as I would in a normal vaginal delivery, because that makes it much clearer what the level is, in an axial direction in the line of the fetal spine, because what you must not do is pull the head to one side or the other, because that increases the traction and increases the risk of injury. And then you say, as soon as I diagnosed shoulder dystocia, I stopped. So that's crucial. So you're allowed 1 pull to make the diagnosis. Then you stop. Then I got 2 assistants to put the mother's legs in McRoberts position and a 3rd assistant to apply suprapubic pressure. Having applied suprapubic pressure, I then applied similar traction as in the first pull, and the baby delivered without any problems, maintaining the pull in the axial direction. And in the case where we successfully defended it, the obstetrician was very clear in what she'd done. She'd written good notes, and in the witness box, she corroborated everything she'd said in the notes and was very clear, and the judge found in favor of the defense that she'd done everything correctly. Now, what happened in the second case, we tried exactly the same defense. The doctor was actually not from India, but from Egypt, and his English was not very good, and he initially described traction as with a normal delivery, axial to the baby. But then the judge got a little suspicious about his ability, and he actually produced a diagram showing the baby in the position and asked the doctor, the obstetrician, who was a consultant, to draw a line indicating the direction of traction. And unfortunately, instead of putting it down the line of the baby's spine, he put it down the middle of the pelvic dimensions, which meant that it was an angle of about 50 degrees to the baby's spine. I then had to go back into the witness box, and the judge said to me then, you're on the side of the defense, but is it acceptable to pull this much to one side downwards when you're delivering? And I had to say, no, that is not acceptable. And in that case, the plaintiff won. So you do actually need to be very specific about the records that you make.
So my point is, most of us...
Kameshri, can I just add a point? If that particular case I were to manage, I would have written first clinically my judgment LFD. I would have taken the ultrasound weight, given her a trial. When the need came for augmentation of oxytocin, I would have taken my cesarean decision, because it is important that it is not just CPT, there's also a shoulder to come after it. So when the need came for oxytocin, that immediately I would have taken my decision. This is an LFD patient. There's a slow progress in the first stage. It's better, she's better off with the cesarean. 4.5 is an indication per se by itself.
No, 4.51 they didn't know before.
They didn't know
After
the science.
delivery,
So
madam.
therefore-
Clinical judgment is, even if your ultrasound, your clinical judgment is, you should never give up your clinical
No,
judgment.
it's generally accepted in the courts in the United Kingdom that ultrasound assessment of fetal weight is not accurate
Yes.
and will not be taken
With
as clear
15%
evidence.
error. So you have to then be doing lot of cesarean sections to
That's why I
escape
said your
this
clinical
scenario.
judgment. Your clinical judgment is very important. And when you notice that there was prolonged first stage, and then when you had to augment, a multi to augment, what's the need? Is there a problem? Is it telling you something? Probably the decision should have been taken.
Fair enough. That comes with
Rather
experience.
than to manage the shoulder
Yes.
dystocia, I would have managed her earlier.
Sure.
before that.
Experience counts. In a multi-starting Synto, alarm bells should ring. Anyway,
My
my point is,
first
just
reaction.
if I can, yes, how to describe traction. Because all the time we have performers, we follow Royal College performer to the core, which we did in this, but it doesn't define traction as you did.
Well, I can define it in newtons, if you like. It should be traction of not more than 100 newtons. And I
But-
have actually had my practice in a mannequin measured by Tim Draycott, and I managed to deliver a very large baby with shoulder dystocia without applying more than 100 newtons by appropriate maneuvers. And I was actually being watched by the assistant medical
So do you think we
officer
should
of
all
the UK.
give traction and measure our
No,
force?
you need to learn the level of traction that's allowed, and you can do that using simulators.
Mr. Cunningham,
and
you
secondly, you
wanted
have to
to say
describe
something.
it carefully in your notes and emphasize the key emphasis. It's in the guideline, not more than you would employ during a normal delivery. And if you want to be really clever, you can say, and I know that it should be less than 100 newtons, and I can do that on the mannequin.
Okay,
Then
so
you're really safe.
learning points, how to write traction. Mr. Cunningham.
I think my question to Professor Steer, I think, we like to assume we can win the game, you know, and do you think it is always possible to deliver a baby with shoulder dystocia uninjured? You know?
No.
No.
And you will not be
No.
held liable for that,
No.
provided you've carried out the appropriate maneuvers, which may include, for example, delivering the posterior shoulder. And if you can give good evidence, you've been on the also course, you've practiced on the mannequin, you know the traction that's required, you can describe it in court correctly, the direction of traction, and you describe the maneuvers appropriately, even if the baby is then damaged, I know from experience the judge will say you're not guilty.
Because, and the reason I ask that question is because I know when bad things happen, trainees take it personally. You know,
Yes.
they do take it personally.
Yeah.
And they feel they could have done better, you know, and you know.
How many of you have done also course? It is available in most of the cities in India now. It's time that you register and do an also course and pass the test. It goes in your favor if people litigate. Okay. Allegations in this case, failure to recognize macrosomia, elective section, not hindsight is a very good thing, isn't it? You can write everything after knowing the outcome. Despite delay in first stage, they did not recognize the big baby. Emergency cesarean was not offered. Even then, excessive traction was applied. And once it was recognized, they did not manage my baby well. So these were all the claims that she did. Yes, it is unpredictable. But as Mr. Steer said, failure to anticipate all shoulder dystocias is not deemed as negligent. Following a meeting of the experts instructed by the claimant and defendant, it was agreed that management in this case was within an acceptable range of practice and there was no breach of duty because there was good documentation and they followed the steps of helper mnemonic in this particular case. The only place where we faltered were the traction. We did not describe as Professor Steer said. So again, as Professor Steer said, Erb's palsy, shoulder dystocia is not the only cause. If we, now more and more explanations are coming, damage may be associated with difficulty in delivering shoulders rather than caused by it. It can be congenital. The propulsive nature of stretching of nerve roots during the negotiation through pelvic canal can cause it. Precipitate second stage can cause this. So other plausible explanations are coming up to defend Erb's palsy. a solace to us, clinicians, maybe. But I have to refer to this Montgomery versus Lanarkshire case. Would you want to throw some light on this? Or shall I read it out for the benefit of... It's much of a coincidence. My first job as a SHO was in this hospital, and it happened in the second week of my job there, this case.
I think what Montgomery is bringing into question is how well we counsel our patients and how informed the consent they give. So in essence, in this case, there were concerns about the potential for shoulder dystocia, but it wasn't discussed. And the question is, should it have been discussed? And when would you set that threshold for discussion? So are we going to discuss every patient who's got a birth weight over the 90th centile on a scan at 36 weeks? Should we be discussing the risk of shoulder dystocia with them? And I think that's the practical question that it's thrown up, really.
This lady actually won the case in the first court. Although she expressed concerns about the size of the baby, the risk of shoulder dystocia was never discussed with her. Her consultant, who advised a vaginal delivery, defended her practice, saying that, in her estimation, the risk of a grave problem for the baby arising as a result of shoulder dystocia was very small. The baby was delivered by forceps, but this was complicated by shoulder dystocia. It took 12 minutes to get this baby out, and obviously suffered cerebral palsy. But she contested in the Supreme Court, and she won this case. I mean, I have no time to read this, but interested people go through the arguments. It may very well happen to us. We need to wake up and follow the right path. So read these cases, be aware of these medical legal laws and cases that lead to landmark rulings that will help us in our documentation and things.
Yeah, I just wanted to comment. There are a number of leading legal authorities and indeed medical authorities that describe this as the most important legal case in the UK in the last 50 years.
Yes.
And the key difference is that it says there is a duty of openness and honesty with the patient. And there was a leading article in the Journal of the American Medical Association which said that it's also already having a major effect in the United States, and that in future it's not a question of having patient-centered care, but the patient must take an active part in their management. And it's something I've always felt passionate about, that we should explain all the alternatives and the options to women, and in the end, they make the decision about which type of care they want, and provided they have been given the full information, that's their right, and it's our duty to facilitate.
To tell, and that's how she won this case. Correct. On that ground. Yeah.
So, can I ask this hypothetical question? At 36 weeks, we're presented with a birth weight, an estimated fetal weight, which is above the 90th centile, and it's likely to stay that way. And the patient says to you, "Thank you, doctor, I'm concerned about the prospect of shoulder dystocia, given the risk that you've then told me. I'd like to have an elective cesarean section, please."
Yes.
And then the baby turns out smaller than expected.
I have always supported the right of women to choose their mode of delivery, and this is based, there was a consensus meeting about 5 years ago held by the NIH in the States, and they reviewed all the data very thoroughly. And if we're talking about particularly the first pregnancy, or the first time when the cesarean is an option, the evidence that there is a significant difference in mortality and morbidity between an uncomplicated or an elective cesarean section and a vaginal delivery, which may be straightforward but may be very complicated, there is very little to choose between them medically. And therefore, they decided that there was no evident basis on which you should insist on one form of management or the other. Now, I have colleagues who take a different view, and they will not do a cesarean at maternal request. However, the national guidelines are very
Second
clear
opinion.
that in that case, you should refer, it's like women who, doctors who refuse to do a termination of pregnancy.
Yes.
You have a medical and legal and ethical duty to refer to someone else who may take a different view.
Sure.
And I think that anyone who refuses to do a cesarean section is actually on slightly difficult ground. And for example, I have been interrogated on national daytime TV by natural childbirth advocates say, "How dare you do this major operation on a woman just because she says she wants it?" And I can honestly say I have never done an elective cesarean on a woman who didn't have a reason that she thought was very important. And just to give you one such example, about 2 weeks after I delivered somebody and she came back just for a review, she eventually confided in me that she'd been with her sister in the Middle East in labor, and her sister had died during labor. And she was so traumatized, she'd previously felt unable to talk about it, and that's why she wanted a cesarean section. And in my experience, there's nearly always something like that.
We should obviously listen to our patient and involve her, as you said.
But they have to know the risks.
Yes.
So it's very important that you give them full documentation of the risks and the risks in subsequent pregnancies.
Yes,
For example,
including Akrita.
And the increased rate of stillbirth. In fact, I'm involved in a case at the moment where a woman had a cesarean in the first pregnancy, and she was allowed to go to 41 weeks in the next pregnancy, and was not told that there's doubling of the risk of stillbirth, most of which occurs between 39 and 41 weeks in subsequent pregnancies. And she's now saying if she'd been told that, she would have asked for an elective section again at 39 weeks. So it's quite complicated.
Yes. So consent is not just a piece of paper where patient signs. So we need to now, it should be a valid consent. We need to explain all the benefits, risks, what are the alternatives, and if she did one option, what are the risks, what are the benefits, if she did the other option, what are the risks, have to be written in the notes. Only that will protect us.
Shall I just add, I personally haven't asked a woman to sign a consent form in 30 years. What I do is write extensive notes about the discussions, and if necessary, we record the discussion so the mother can keep it permanently.
Who consents your patients?
Sorry?
Who consents your patients?
They consent themselves.
Wow, okay.
You know, in emergency cesareans, for example, in our hospital, in the last 30 years, it's a rule that we do not ask the woman to sign a consent form because it's an unnecessary distraction. She's distressed, she may have a lot of analgesia on board.
Is it the same rule in stroke?
And it slows the cesarean, and the idea of a junior doctor waving a piece of paper over somebody saying, sign here when they're being wheeled into theatre is ridiculous, and it's completely unnecessary and has no legal value. And I can show you opinions from very leading experts in the UK that say it's not only not of value, it's actually going to be held against you because it interfered with your procedure.
True. Yes, suppose we want to do a peripartum hysterectomy as an emergency, how to take the consent, sir? Suppose we start the cesarean, but somehow the bleeding is not there. We were compelled to do a peripartum hysterectomy.
Is the mother conscious?
Mother is not under GA.
If the mother's unconscious, then you must explain to the family what you need to do to save the mother's life. And ultimately, your defense is that the procedure was done appropriately and was necessary. If it is, no one will ever convict you of doing anything inappropriate. Yeah. Saving life is something that doctors are meant to do in the United Kingdom.
The medical legal position is it's called a declaration of necessity, where you can act without consent to save the person's life. So it's kind of recognised. But to answer your question, in Stoke, we've gone the opposite way in some ways in that our consent form is now married to our WHO checklist.
Yes.
So everything's got to be done.
Yes, documented. You know. And the consent should be by a person who has done that procedure before and not the junior most or a nurse. They should not be taking consent.
The thing that should be avoided is this expression, the patient was consented. There's no such thing. They either gave consent, in which case you have to explain why they gave consent, or not. It's not something you do to people, it's something they do.
Yes, yes, agree. It should be voluntary. So now we have only 10 minutes left. So we'll breeze through 3-4 cases so the audience gets a flavor, and I would appreciate quick, crisp answers so that we get through all the cases. Here is a second gravida. She had first was a normal delivery in a town near Hyderabad, 3.5 kilos. This is the second pregnancy. 3.5 kilo baby, spontaneous delivery, sustained a perineal tear. The consultant has repaired the tear, and the notes written in that discharge summary is that perineal tear repaired in layers. Then she gave a history of passing feces through the vagina 2 days, on the 3rd day, and she was referred to our hospital in March on the 4th day. So what could have gone wrong here? Very quick, one-word answers.
The primary consent should have overlooked it. She might have missed a...
So what do you suspect?
It was a
3rd or 4th degree tear.
It was overlooked, and she repaired only the perineal
Documentation is poor. Diagnosis probably doubtful.
Should have been examined clearly in a good light, good position, and should have not missed it. And if she is not capable of doing it, ask her seniors to do it.
Exactly. First repair is the best repair. So subsequently, you will see what went on with this patient. So OAC happening is not substandard care, but what is substandard is you didn't diagnose it, you didn't document your repair well, you didn't show that you have followed the safe surgery principles, no explanation. Patient didn't know anything. The doctor just told me to go to your hospital, that's all. And they didn't follow up, okay? So what happened in our hospital, examination confirmed wound breakdown, high rectal mucosal tear, extensive counts. We involved a colorectal surgeon because it's already 4th or 5th day by the time she arrived with us. And the need for repair and possibility of repeat breakdown was explained to her, including the option in future risk of colostomy. So she refused a colostomy as a first step and agreed for the colorectal surgeon to do a second repair vaginally, which he did. It was done, sphincteroplasty was done. She was discharged on the 23rd, readmitted only the next day with similar complaints. The wound breakdown occurred again with gaping of the posterior vaginal walls communicating directly with the rectum, so it unfortunately broke down. And obviously what went on is she had a colostomy. The perineal wound was left to heal by secondary intention. Now, it's happened in March. Now she's continent. She just had her colostomy reversal also, 8 months since her delivery. And a similar case I can recall in the UK when I just joined Neville Barnes forceps, and that registrar in the operating vaginal delivery notes has documented right mediolateral episiotomy repaired in layers. And 3rd day passing feces, junior SHO was called, did not find any problem, then again called the registrar the next day. There was a buttonhole tear, they tried to repair it, but wound broke down 2 weeks later, left to heal by secondary intention, did not heal. She also ended up massive lawsuit, massive compensations. So these all are now happening in India also. So we need to wake up to this. So what are the learning points? Now we are saying to our junior doctors, OAC training is mandatory because the quality of life deterioration with not diagnosing OAC is terrible. It spoils everything for that new mother. So we need to diagnose, we need to do a good repair, we need to follow. There is a nice green top guideline stating the surgical principles, what is recommended for each layer, what sutures and everything. Document well, use a checklist, talk to the patient. Most often patients come after this repair into my OP and they say, I don't know what happened, but they took me to theater and they repaired me for 2 hours. This is what they say. They have no idea what was done. So we need to really use leaflets, pictures, and explain to them what actually happened and what are the future implications. We will not go into this. OAC can be prevented. A lot of new research is coming about the control head delivery, and previously they used to say hands off. Now perineal support is again coming back with these two, controlled head delivery and patient education at the time of crowning makes a lot of difference and reduces OAC. A lot of papers are there. We'll skip it for want of time. Even a new device. I have no experience. Either of you have any experience with this new device, perineal protection device? I haven't got, so let's wait for it. Can all these be prevented by a cesarean section? Most often people ask, obstetricians ask, you have to do 250 cesarean sections in a primary to prevent one OAC and almost 160 to prevent one in a multi, and I don't think it's worth it. We should make vaginal delivery more safer, take all precautions. Now the angle of episiotomy is supposed to be 60 degrees and not 45 degrees. So be mindful of the angle. Every 6 degrees away reduces the risk reduction from the midline, reduces the risk of OAC. So keep all these and use a checklist. We use this checklist in our hospital. We ask them to draw in this, so the extent of trauma, so that they don't miss out anything. The antibiotics, the laxatives, the debriefing, everything is there. So anything any of you panelists want to add?
I think just that one of my, perennial bugbears is blunt scissors. Trying to do a decent episiotomy with a pair of blunt scissors.
Exactly.
It's very difficult,
And most often, when the head is crowning, we would think it's 45 degrees, but it's not. After delivery, you see that it's some 20, 25 degrees.
Absolutely.
So be mindful of the angle where you give the incision.
But just one word of caution, when you've done the CPT, I mean complete perineal tear repair, and in case it breaks down, I would say don't go for an immediate repair, wait for 3 months. Many times it resolves, and then when you repair it, maybe you'll be more successful. Because this was done soon after, rather than that once you have failed, wait. They may actually have a lot of qualms about waiting, but then you'll have to advise them that once it waits, it gets circumscribed well, the tissues are well formed, good fibrotic tissue, and then when you do the repair, you're normally successful.
But 3 months of torture to the patient.
Yeah, 3 months of torture to the patient.
Otherwise, it will again break down and vital vein colostomy.
Yes.
Again, not for third-degree tears, but if our episiotomies break down, we debride them and resuture now. We don't go for the secondary healing option.
Oh, you resuture?
Yeah,
okay.
Even if they come back after a week, 10 days, we would debride and resuture. Yeah.
Do you use any different suture material or the same micro
Just
rapid?
the same, the same. Because we've debrided it, we get a good apposition, and you know that's. I think that's down to the interest of the team. They've done extensive studies on that to show benefit for women, both quantitative and qualitative as well. So.
Right, so we have a pro forma to follow up these patients. It's important to not just repair and forget about them. 6 weeks, 6 months, and up to a year would be ideal. Anyway, quickly, I think I have 3 minutes left. Case 4, 24-year-old polycystic ovarian disease. I think this is happening more and more. This case is to reflect the abnormal or atypical trends of serum beta-HCG in the diagnosis of ectopics. Her first pregnancy was a termination. Second was a missed miscarriage. This is the third current pregnancy. 64 days of missed period, urine test positive. Obviously, so early on, the vaginal scan was inconclusive, so we did beta-HCGs, which showed 781 on the 20th. She did not return on the 22nd. Instead, she did on the 24th, which is 4 days down the line, and the beta-HCG was 2,600. And then we did another one to make it 48 hours apart to interpret. It is 4,551. So the rise is around 60%. The dictum is it should double, no longer held valid, because pregnancies intrauterine have been reported with even 50% rise. So we are seeing this more and more. So be a bit cautious. So no typical sac. We scanned her on the 26th. We couldn't see a sac. So we did LFTs and everything and mentally prepared her for a methotrexate. The patient came back the next day. Before taking methotrexate, she just asked us, please, would you check for me again? And to our horror, we saw an intrauterine gestation sac. Isn't it scary? We would have killed this baby if you had given the methotrexate. She is still continuing her pregnancy at 11 weeks. I've put this on just to alert you all, don't be hasty. Yes, it didn't show doubling. Uterus is empty. At 4,000, ideally, we should see a sac. It didn't happen. She was asymptomatic, and these atypical trends do occur.
When you did that first scan, who did it, and how many times did they do it? Can you tell us that?
It was done by a registrar level who had scan training, and it was done once.
Right. I always had a rule that before intervening in anyone, I would get a second scan done by another person, preferably somebody senior and experienced. And that this had, even when it confirmed that there was, for example, a missed miscarriage or something like this, the big advantage for the woman was that she didn't spend the rest of her life wondering, I wonder if that doctor got it right. Because when two doctors independently, very carefully come to the same conclusion, it's much easier for her to accept that this pregnancy is not viable.
We follow
and it's actually
that
easier for me to accept it as well.
We follow that for missed miscarriages when the heartbeat is absent, but for this, we didn't ask for a second person to scan.
But we have a rule that if it's above 1,000, you must find the gestation sac somewhere.
Yes.
And if you can't, then you need somebody who's better at scanning than you are.
The person who scanned is supposedly trained.
Before you give a methotrexate, word of caution, be 100% sure it's an ectopic before you give methotrexate. Otherwise, there's something called weight.
Yes.
WAIT is very important. Yeah, or you go for a second opinion.
What I want to say is the 60% rise is quite an accepted fact.
Yes.
It is 60%. You are supposed to have a 60% in 20.
Even with 53, as well as 35%, we are seeing intrauterine pregnancies showing
If she's
up.
asymptomatic, you just wait, until you
Yes.
find out.
But,
I agree.
but the issue is not just whether that person was properly trained, it was the fact that it was a different set of eyes, fresh eyes, if you like. It's not meant to say that they couldn't scan, but we all know that you can do a scan and not find something. And then simultaneously,
Maybe
your
we
colleague may not find something, and you do a
Sure.
scan and you find it straight away.
True.
It's simply the fresh
So
eyes.
maybe even
And
before
with
giving
intra-
methotrexate, it's good to have a second person
Yeah,
scanning,
correct.
just like we do for a missed
And
miscarriage.
medico
diagnosis.
legally, it's much safer.
Absolutely.
With intrauterine gestation, it's known that you can have a localized contraction and not see the pregnancy.
Sure.
Transient.
I have 2 cases. Can I take 10 minutes? That's great. Because there are learning points. I hope you are learning from the experts. Please put this in practice. These are useful tips to save our own skin. Now, retain foreign bodies. It happens time and again. Here is a lady. I'm not sure. This is another one. Is there a policy in all your institutes is what I wanted to ask. Because this happens again and again. So the simple answer is count, count, count again. Double count, as fresh eye. Even if the first person is inattentive, the second person may be more alert. And, you know, ultimately the responsibility is the surgeon's. Am I right? Can the surgeon get away saying, I was too stressed in the hemorrhage and
One of my
I didn't see?
ex-trainees, Helen Bolton, has just written an article in the BJOG in the last month or two about this sort of thing, particularly with retained swabs at vaginal delivery, and this is technically called a never event. And of course, what that
Yes.
means is it should never happen. So
Never happen.
automatically, if it does happen, you're at fault. Now, one way is to try and take extra precautions yourself, and asking for a second opinion in this situation is probably not very practical. And what she suggested, and I think we should adopt, is that you never put anything into the vagina or indeed into the body without either
tag.
with a radio opaque container or a tab or a string
Yes.
to make sure that that's always outside, because then you can always know that you've left something. So this could be seen as a systems re-engineering approach. Always blaming the individual is not going to stop it happening. What you need to do is re-engineer the situation to make it much less likely that anyone will make that mistake.
Yes.
The other side of this is that we had a case where somebody presented 6 weeks to the general practitioner with a swab that they said they'd taken out. General practitioner disposed of the swab. We checked our documentation and we couldn't defend it. You know, we couldn't prove it was our swab, but at the same time we couldn't defend it because our documentation was so poor.
Yes.
So I mean,
So
that
it
is
speaks
the
for
other
itself.
That is the other side of it.
Yes,
You
it
know,
speaks. No defense.
That's a phrase that the lawyers use a lot in the Latin, res ipse loquitur. The thing speaks for itself. And if
Yes.
there's something there that shouldn't be there,
Yes.
somebody
Yes.
has left it there.
Yes.
And it matters less to the lawyers who left it as the fact that it should never have been there.
So our systems changed after we had 3 or 4 of these over 6 months, was that instead of having the little swabs, we got rid of those completely, and every swab now is one of the big ones.
With the radio opaque
and
material in
with
it.
the tab, with the string on it, so that
So
you...
we don't have the little swabs anymore.
Yes.
Really.
Everybody should have a policy in your own institute. 2 people should count. I can recollect a case of my colleague. They spent from morning till evening searching for a swab intra-abdominally. She started a total laparoscopic hysterectomy. There was bleeding and something, she looked suspicious, that ovary looked malignant, which was not picked up on scans or anything. She found it very suspicious. She took a frozen and sent, waited. Frozen confirmed malignancy. She called the oncosurgeon. They did a laparotomy. In that mad change of staff, somewhere something went wrong, and at the end of closure at 5 p.m., one big mop was missing. Okay, so they counted, the surgeon he would close the rectus sheath, he reopened, he checked, nowhere it is there. And the sad part which came out in that is the morning sister, when she finished her shift, the swabs, whatever have been thrown, were binned and sent down. So they went down, retrieved the bag and checked, and still it wasn't there. Ultimately, she was sent for an X-ray, wasn't found. In the end, what they concluded is that when they opened the pack, instead of being 5, there were only 4. But there is no proof. So she had so much of counseling to do with the family and the patient, saying This is what has happened. We did everything possible. We documented in the notes. We did a CT at our own expense to look for it, and we explained to them what happened. And after that, this WHO checklist is being followed more meticulously, and the surgeon or the assistant who's going to watch for the case has to be there when they are counting the swab, when they're opening, to check are they 4 or 5. It's a human error. They can put only 4 and pack it, and we assume there should be 5. But it didn't occur, and it wasted a whole day of anesthesia to the patient, morbidity, unnecessary tests, expense, and stress to the surgeon. The surgeon is called the second victim. You hear the second victim theory now. The first victim is the patient. The second victim is the surgeon, the healthcare professional, because who looks at our stress? We suffer in silence. Because equally, it's like loss of a family. Or, you know, you don't want to go to work if you know that your case is litigating. You feel terrible. But who supports us? So that's another thing. And the third victim is the organization. The organization has to bail us out. So these theories are all coming up. A lot of support is needed for the surgeon as well. Now, I will end with case 5. I will not take much more time. But this has many learning points, and it occurred in our hospital. And it's a learning point for the obstetrician. 34-weeker, referred for premature labor. She was treated outside for 2 days with IV ritodrine, which is duodeline, which is not a drug we use in our hospital. We use nifedipine. But anyway, her pain did not subside, and the obstetrician, she was referred to us. One loose statement is enough to instigate the patients. Okay, so the obstetrician who was on duty, you're in labor and you need cesarean and there was too much delay or whatever, something. It's already delayed because they put a CTG and there were some decels. So inadvertently, the doctor who attended said, oh, it's already delayed, something like that. And without his knowledge, the family went to the primary obstetrician and ransacked her nursing home and said, you delayed this, you caused this to, the baby came out poorly and is in an ICU. So that is beside the point. What happened with the woman? She underwent cesarean section. At cesarean, the obstetrician found some exudative flakes. He didn't think much of it. He gave a wash and closed. No further exploration was done. Okay? So pyrexia from day 5. She's tachycardic, not settling down. Continued antibiotics, 2 more days. Again, signs suggestive of systemic toxicity. Guarding. General surgeon was called. People hesitate because she's day 5. They attribute some of these symptoms to the cesarean. It's not easy for the surgeon also to decide, oh, I'm going to open up again. So there were signs of generalized peritonitis. And what did the laparotomy find? Perforated gangrenous appendix. She had prolonged ICU stay, and TPN and everything was required, and the opening was horrible because we were there. Everything is matted, there's pus everywhere, and serious risk of bowel injury. So what is the learning point from this? We are not blaming anyone, but we should learn from this. Do not make any loose statements. As Mr. Steer said, we'll take his point that that is not our problem. We have to deal with the patient from the time she comes to us and not make any instigating statements, but just do your job. If flakes, pus seen, we must explore. What are the sources for pus? Appendix, tubes, DO abscess, at least those. Suppose you are not sure, call a surgeon on table before closing, because seeing pus is not normal. So we must learn from that. And post-operatively, a lot of dilemma to reopen, to wait, and difficult relap, and so on. So we mustn't hesitate to image a patient. She was treated as premature labor, whereas actually her cause was appendicitis. And for fear of imaging a pregnant woman, people don't. So we actually have to weigh the risk, small risk of radiation versus all this morbidity. And we mustn't penalize the woman for being pregnant. The exposure is as small as 5 rads. So there are good imaging techniques available now, and we should not hesitate to do a laparotomy. Even if it's negative, it's always wise to look and see rather than wait and see in such cases. And mortality, you know, I don't have to talk about appendicitis, but the mortality complicating pregnancy is the mortality of delay. Most often we hesitate. We think it is labor. We have tunnel vision. We only focus on the uterus. But this is a big learning lesson, and we spoke about this. There are many more cases, but we will end it here. I hope you have gained something from our experiences, and hopefully you will change your practice. I thank all our panelists for voicing their opinions, lot of learning points. Thank you very much. This last slide, I put it on purpose, and I thought Mr. Steer will make a comment. Doctors don't make mistakes, and when they do, should we say, should we don't? But now we must disclose. We cannot cover up. For our own ethics, for our own morality, we have to explain to the patient. We are also human. In fact, patients appreciate if we are honest and say, look, I have made a mistake, and write it in the notes. They might be a little kinder to us. Thank you.
Good afternoon, everyone. Thanks for inviting me to be part of these advances, which I think I've been participating in year after year, and as always, a wonderfully organized meeting. The topic is management of persistent trophoblastic disease. Basically, we need to know what exactly is persistent trophoblastic disease. It is also referred to as gestational trophoblastic neoplasia. Please remember, there is a trophoblastic disease is not malignant, not all malignant, because it includes high dactyliform mole or vesicular mole, which is benign, and the malignant counterparts. But the persistent trophoblastic disease actually is the gestational trophoblastic neoplasia, and only includes those which are locally malignant or metastatic. So the disease that does not resolve after molar evacuation, or that becomes malignant and requires active management. Is there a point? Okay. Abnormal proliferation of basically there's abnormal proliferation of the trophoblastic tissue, and GTN, this gestational trophoblastic neoplasia, may follow either vesicular mole or non-molar pregnancy. So GTN may be an invasive mole, choriocarcinoma, placental site trophoblastic tumor, or an epithelioid trophoblastic tumor. Please remember, these two are extremely rare. So we are basically talking about invasive mole, which is locally invasive, and choriocarcinoma, which can metastasize. Now, these are usually diagnosed by persistent elevation of beta HCG, and histological diagnosis is not mandatory, and that is what you need to remember, because it's not possible always to get a histological diagnosis, and it's not really absolutely essential. The HCG levels are grossly elevated in invasive mole and choriocarcinoma, but in placental site tumor and epithelioid trophoblastic tumor, the levels are generally low, and that is why it is very difficult to diagnose these two. The mortality in metastatic choriocarcinoma was nearly 100% about say 2 decades ago, but it has come down markedly, significantly, because of ultrasonography and other imaging modalities, including MRI and CT. HCG being used as a biomarker, and advances in chemotherapy, and therefore now the survival, as I will put up a slide later, is actually very good even in metastatic disease. 15 to 20% of women who have trophoblastic actually develop after a complete evacuation of a complete mole, and 2 to 4% after a partial mole. So majority of them actually come back after a complete mole, and of these which become persistent disease, 15% have invasive disease and 5% have metastatic disease. When I say invasive, I mean locally. And the sites of metastasis I've given, and I'm sure having handled so many patients with trophoblastic tumor, all of us know that pulmonary is the most common. All of us have seen vaginal metastasis, and occasionally CNS and liver metastasis as well. So the risk factors for development of trophoblastic neoplasia or persistent disease after evacuation of a mole, all of us know, all undergraduate textbooks give you this detail, that is a very large uterus, very high levels of re-evacuation HCG, large thicker luteins, again which reflects a high level of beta HCG, and older age group and race are the risk factors. But there are people who even give a prophylactic chemotherapy when there is these high risk factors are present, in order to prevent invasive or persistent trophoblastic neoplasia, but considering that it only occurs in a small number of patients following evacuation of a mole, where people have worked out the cost-effective ratio and cost-benefit ratio, and the recommendation is not to give prophylactic chemotherapy for all of them, because very good method of follow-up and sensitive methods of follow-up using beta-HCG is available, and you can actually wait to see if they develop a persistent disease and then use the chemotherapy. Now, the diagnosis of persistent disease, as I told you, most often diagnosed during follow-up after molar pregnancy. I mean, all of us know that's what happens. You're following up these women and then the HCG titers just keep going up or they come back with symptoms. And so that is how, because if you're, those that occur following a full-term delivery or following an ectopic are all very rare. So most often we see them in this kind of situation. And as you all know, the recommendation following evacuation of a mole is to do weekly beta-HCG till 3 consecutive normal values and then monthly, etc., etc. And you need to recommend contraception. Oral contraceptive is what is recommended despite a whole lot of controversy about whether it increases the risk of persistent invasive disease or not. Now we know that that's what is the most effective. And what you need to remember is that specific beta-HCG assays must be used. It must be capable of detecting baseline values of less than 5 milli-international units, and the same lab should be used for serial follow-up. When you don't do this is when you have confusion. You have a value of 70 now and 85 next week, and these things happen when you change the lab and you use a not so sensitive test. Now, how do we diagnose? There are very definite recommendation by oncology committees. You know that if they plateau for 4 measurements over a 3-week period, or when there is a rise of beta-HCG for 3 consecutive weeks, or there is a it remains elevated, and these are the criteria. I mean, all your books give these, and these are actually criteria recommendation which came out in 2002 and again reiterated in 2012. Now, the diagnosis, once you find you have a patient who has got elevated beta-HCG while you are following up after evacuation of mole, you're doing weekly, and then what came down started going up, or it plateaued, or it started remaining the same, you need to now go back and take a history, find out if she has bleeding, find out if the uterus is enlarged. You need to basically examine her. Are there ovarian cysts? Is there a hypothyroidism? That's very rare now. And of course, you need to image. All of us will immediately take her for an ultrasonography, look for thecal lutic cysts, lung metastasis, liver metastasis, and of course, you might want to look for a histopathology. But as I told you, a repeat curettage for the diagnosis of an invasive mole or choriocarcinoma is not necessary, and most people advise against it because the risk of perforation. Curettage is with the dangers of perforation, hemorrhage, and cannot diagnose an invasive mole because it's in the myometrium anyway, and biopsy of metastatic lesions is not required, and treatment is based on elevated HCG only. So please remember that, and that is a definite take-home point, because all of us have had a situation where the postgraduate has curated because somebody came back with bleeding, and then we've had perforations and other complications. So in a woman there is with no history of molar pregnancy, maybe she's had a normal delivery some time ago, and then she presents with usually they present with abnormal uterine bleeding or amenorrhea, HCG stimulation effects like ovarian cysts or hypothyroidism. They could have symptoms of metastasis depending on where the metastasis is. Vaginal bleeding from a nodule is pretty common, headache, neuropathy, epigastric pain, and jaundice if there is liver metastasis. So when you see a patient who presents to you with these symptoms after a normal delivery which happened a year or so ago, you need to have a you need to think choriocarcinoma, because it's easy to miss that and go about evaluating for various other things. And the confirmation of diagnosis here following clinical examination with serum HCG is always by imaging. So history, as I already said, you need to also get the details of duration, interval from the antecedent pregnancy, nature of the antecedent pregnancy, because all these are important for your scoring later. So note down all this when you see the patient, and prior treatment details, clinical examination, of course all the systems that could be affected, general examination, respiratory system, abdomen, CNS, speculum, and pelvic examination. You must look for a urethral nodule, and it could easily be missed if you don't really put in a speculum and just do a pelvic or a bimanual pelvic examination. You need to look to see the nodule there. Further evaluation, of course, is by ultrasonography or CT of the abdomen and pelvis to look for pelvic disease and liver metastasis. Chest X-ray is absolutely mandatory because remember, pulmonary metastasis comes first. After the pelvis, it's always there. And of course, if the lung metastasis is present, you need to do a CT or MRI of brain. If pulmonary metastasis is not there, there is no need to evaluate the brain. And that is the sequence in which it always goes. So the recommendation is only if pulmonary metastasis is present, you do a CT or an MRI of the brain. And of course, serometric beta hCG levels are mandatory. What are the pelvic ultrasonography findings in GTM? Invasive mole generally has a poorly defined mass of the uterus with high vascular flow on Doppler. Choriocarcinoma generally is a mass in the uterus, inside the uterine cavity with necrosis and hemorrhage. PSTT and epithelioid trophoblastic tumor are very difficult to diagnose. They all actually appear as a vascular hyperechoic lesions either in the uterine wall or in the cavity, and unless you actually biopsy it or curate it, you are never going to come up with a diagnosis of either of these two. Even though after you have diagnosis, you may go back and look at your film and say, oh, okay, this is a characteristic picture. No one has ever come up with a diagnosis of a PSTT or a epithelioid tumor just by looking at the ultrasonography reports. And this is just to show you that this is how vascular it is in choriocarcinoma, and all of you know the picture on pulmonary metastasis. So after you have taken a history, done a clinical examination, and done all this evaluation by way of ultrasonography, CT bar, MRI bar, whatever, you need to do two things. Number one is FIGO staging of the disease. All of you know it, so I'm not really going to repeat it. Either it's confined to the pelvis or to the uterus, pelvis, or lung metastasis or brain and liver metastasis. And the second thing is the modified WHO scoring. And the scoring is given in all your books, and so I'm not putting it up. Score of less than 6 is considered low risk, and that of more than 7 is considered high risk and usually require combination therapy. So this scoring helps you basically to decide whether you want to give a single agent chemotherapy or a combination. And remember that FIGO stage 1 have low scores and low risk disease, almost all of them. If the disease is only in the uterus, it's going to be definitely, the score is going to be definitely less than 6. Whereas FIGO stage 4, where there's brain metastasis, it's going to be high risk and definitely going to be multi-agent. So where is scoring useful? It's very useful in stage 2 and 3, which may be this way or that way. So you look at the stage and then you score the disease and decide what treatment you want to give. So the management of low risk metastatic disease, which is stage 1 bar 2, score 1 to 6, if fertility preservation is not required, as in an older woman, hysterectomy is advised. And of course, it has to be followed with chemotherapy. People even give chemo at the time of surgery because it reduces tumor dissemination, maintains cytotoxic levels to destroy cells, and treats metastasis already present. But this has to be followed with at least a few cycles of chemotherapy. But if fertility preservation is desired, the single agent chemotherapy, as I said, is what is indicated. Now, methotrexate is the most commonly used drug. It is recommended as the choice of treatment by ACOG. The remission rate is 80% and several dosage regimens are available. We all know we use weekly methotrexate. We use with rescue, folinic acid rescue, 1 milligram per kilogram. I don't have to tell you all this. There are other regimens like 5-day regimen of 0.3 to 0.5 milligram per kg, high dose infusions. Now, no high quality data to establish the best regimen. There are no head-to-head randomized comparisons on any of this. The response rate, what's more, is similar in all of them, and so you could use whatever you are comfortable with. Most of us use the folinic acid rescue, and many of us now have switched to the weekly methotrexate because we don't really have to admit them. They come with their bloods, and then you give them the IM injection and send them. So I think these are the most often used ones, and the response rate is very high. Now, actinomycin B, how about it? It is the alternative or the second line, and there are randomized trials comparing actinomycin B weekly and found good response, more often used in methotrexate resistant cases because of the higher toxicity with actinomycin B. How do we follow up these women after low risk disease? They have to be followed up with until 3 HCG levels are normal. You might want to do a consolidation therapy for 2 or 3 cycles more. And monthly levels must be checked for 12 months with definite contraception. And that is mandatory. And 12 months follow-up is what is required. Now, how do we manage high-risk disease? These are the women who have stage 2 or 3. As I told you, not most often not stage 1. 2, 3, they could also be 4 and score more than 6. These, they generally develop drug resistance to a single agent, and that is why you need to do a combination. There's no point in trying a single agent followed by combination for these women. Multi-agent is what we start straight away. We could use an EMACO or an EMA-EP. These are the two drugs, the combination which are used now. Where the co being replaced by platinum and etoposide. Repeated every 2 weeks, 78% complete response in almost 90% overall survival, toxic but well tolerated by most, have no life-threatening toxicity and high fertility rate even following treatment. So EMACO is given every 2 weeks, weekly HCG levels, 3 consecutive levels are negative, consolidation therapy for 3 cycles after that, and then you follow them up for 12 months with adequate contraception. Several other combinations have been used, as I told you, and of course, if they don't respond to this EMACO and EMO-EP, actually we have a problem on our hand. We are going to move on to salvage therapy where the response may not be very good. So management of, what do you do with the high risk, that is stage 4, that is considered, some people call it very high risk, that is stage 4, those who have brain metastasis and liver metastasis. In addition to the EMACO, they all require local therapy to the brain mets and sometimes local therapy to the liver mets and embolization and resection of the liver mets. Here again, it can be intrathecal or cranial irradiation. These women have to be followed for a period of 24 months and not 12 months. So, look, just summing up the treatment by stage. Stage 1 is hysterectomy and 1 course of chemotherapy or single agent chemotherapy depending on the age and reproductive needs of the woman. 2 and 3 score of less than 6 single agent, more than 7 multi-agent, and stage 4 combination with radiation bar surgery. And as I told you, the survival is very good in the even up to stage 3 and is almost 80% in stage 4 disease. How about placental site trophoblastic tumor? Just a few words. It's a rare, difficult to diagnose form of GTM, suspected in women with low levels of HCG following normal pregnancy and presenting with a uterine mass. Curettage may be required to confirm diagnosis, can cause massive bleeding when you cure it, and the treatment is by hysterectomy and chemotherapy. Epithelial trophoblastic tumor is considered a variant of placental site trophoblastic tumor developed from extravenous trophoblast. Discrete solid or cystic lesions, HCG levels are again low, and diagnosis is difficult and therefore diagnosed very late, only after metastasis. Hysterectomy is the treatment of choice. We could give a combination chemotherapy metastasis. So the key points to summarize are there are no major changes in diagnosis, staging or management or scoring in the recent past. Some controversies have been resolved. Duration of follow-up after complete mole has been reduced. Single agent chemotherapy has excellent response rate in low risk disease. Survival after combination chemo, even in high risk stage 4 disease, is as high as 78%. Thanks for your attention.
Thank you very much, Dr. Lakshmi. I request our chairperson, Dr. K. Radha Kumari, to please present a token of our appreciation to our plenary speaker, Dr. Lakshmi Shishadri.
Thank you, Jayakrishnan. Thank you, Niranjana, Ashwin, for always including me in this fantastic conference. It's always a pleasure to be a part of Advances. Our handsome MC, I've been seeing him for several times this time, for the past several years. Thank you so much for making me young and saying that I have practiced only for 25 years. It's much more than that, and I will keep you guessing. And the other thing that you're not aware of is, since you've been attending these OBGYN conferences for so many years, you're going to enter the MD exam. You're going to be writing the MD exam very soon. Right. So I had told Jayakrishnan that since I have quit clinical practice 4 years ago, I would rather not speak on clinical topics, and I am addressing several things which are very dear to my heart, and certainly evidence-based medicine is what we have been trying to practice for the past 34, 35 years. And a question which keeps cropping up, and it's asked of me many times by many Indian physicians, is, do geographic boundaries apply? Let's look at that question and let's see if it really does apply. Okay, this is not moving. The magic and misery of technology. Right. So we all know how the world is divided right now. We know there are developed nations, and we fall under the developing nations or the emerging economies. But the map is very different when it comes to maternal mortality. The map changes completely. It's inflated. Africa and India have the dubious honor of being the place where the largest number of maternal mortality occurs. And this is very important because this is why we need to practice evidence-based medicine. This is why we need to follow protocols and processes, because unless we do this across the country, we are not going to be able to change our numbers. We are not going to be able to become a developed nation when it comes to mothers not dying. What is evidence-based medicine? I have had people who come up to me and say, no, 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 all this is nonsense, evidence-based medicine. We have to practice with our experience. Basically, evidence-based medicine is just best clinical practices based on data, based on data. If somebody tells you the liver is on the right, it's based on evidence. It's based on the fact that several anatomy dissections have been done, and we have proven that the liver is on the right. And how do we define evidence-based medicine? Basically, we take patient values and preferences. We add clinical expertise. We use best data, best evidence that is available. And where all these three intersect is called evidence-based medicine. And it is all in pursuit of best possible outcomes. Which doctor is there who says, oh, I don't want the best possible outcome for my patient? That's all we strive for. That's all we became doctors for. We wanted the best to happen for our patients. So if we take a clinical problem, how do we manage it? Okay, if you see this gentleman dealing with this young boy, okay, you'll say it's intuition. He's able to predict everything. He's an astrologer. He looks at a palmist. He reads his palms. But actually, if you think about it, he's using evidence. He sees this young man wearing jeans, so he's okay. He must have gone to college, young enough, looking sad, love success, love failure. He wants to know if he's going to get this girl that he is going after, or he looks like he wants to get a job in Dubai or Muscat. So he puts all these things together and comes up and says, oh, you've got a foreign travel coming up, and you're going to be accompanied by this girl. Boom, intuition. But actually, it's not intuition. It is evidence. He's put it together based on data that he's collected very quickly. And that's how we make good physicians. If we are going to be good physicians, we take a lot of data, inputs, and then we bring out our diagnosis. Different countries have different guidelines. The RCOG guidelines, the ACOG guidelines, SOGC in Canada. Australia has its guidelines. The Cochrane Library is constantly looking at interventional data. The Reproductive Health Library tells us what works in developing countries. Up to date, I mean, that's my Bible. I cannot live without up to date. It immediately, constantly looks at literature and tells us what is the present evidence for any particular disease. Unfortunately, in India, we have very sporadic evidence. We are not a country with a culture of research. And this is something that we've been trying for a long time. It's not happened, but that's fine. We still can look at evidence. It doesn't necessarily all have to be Indian data. What are guidelines? Where do these guidelines come? They're basically, you take evidence, and then from that, you come up with guidelines. And what is evidence? Good randomized controlled trials, which then become meta-analysis. Systematic reviews are done about using several studies. Summaries come out from this, which give us commentaries, which say, look, this will work in low-resource areas. This will work in a place where all facilities are available. And these guidelines take global evidence and give it to you, and then you use it for local decisions. This is what guidelines are. Let's see how a guideline evolves, right? Let's start with this one simple paper. 95 patients were taken. A randomized controlled trial was done, a double-blind, placebo-controlled, in 1979, where they looked at the efficacy of prophylactic antibiotics in cesarean section in preventing surgical site infections. And they said, you know what? We gave 1 dose of cefazolin, and it worked. Fine, we prevented SSIs. Now, then a meta-analysis was done of 7 studies. Now, more studies had been done. In the Gray Journal, it came out, and they said, you know what? This confirms the initial study. So now you have a meta-analysis. Now, Cochrane did a systematic review in 2014 of 95 studies. Now, why 95 studies? Because everybody can't have such large numbers. You can't do one study with 15,000 patients. But if you take all these studies and you have your very clear criteria for why you have included these studies, now this, you've got 15,000 patients. It's a very good number. And you have said, again, that this is a strong recommendation. We have looked at this. We know that we need to give cefazolin just before you start a cesarean section, and your wound infection rates will be low. Right. Now, you go to RHL, Reproductive Health Library. It's free for all of us. We can all look at it. And they bring out a guideline. They say a single-dose antibiotic prophylaxis with the first-generation cephalosporin. Please remember, we don't have to give cefotaxime. We don't have to give 3 different drugs. We don't have to give multiple doses. A single dose, 2 grams of cefazolin, is recommended for all women undergoing cesarean section and should be an audited standard. So if you are getting too many wound infections in your institution, people should be able to look at your data and say, you know what, you're not following this. So you are breaking the rules, and therefore, there's some punitive action can be taken, or at least you can recommend it, or you can say you have to change your protocols, right? So this should be an audited standard. Now, do geographic boundaries apply? No. If you have a standard based on such good evidence, you don't have to say that geographic boundaries can be applied. The number one myth is Indian women differ from other nationalities. When I came back after finishing my residency in 1981, I was very surprised that every woman here was given 40 milligrams of gentamicin, whereas I knew the dosage I had been taught during my residency that was 80 milligrams. And I asked the physicians, why 40 milligrams? Oh, Indian women. We need only 40 milligrams. Where were based on what? What evidence? Nothing. Just the fact that we are Indian women and we are delicate and we are fragile and we can't take 80 milligrams of gentamicin, we can only take 40 milligrams. Now look at this, US Senator Pramila Jayapal from Tamil Nadu. She is a senator and her entire genetic pool comes from Tamil Nadu, where I come from. The UK Minister Preeti Patel. Now, Pramila Jayapal is going to be treated with guidelines from ACOG. Preeti Patel is going to get all the guidelines given by the RCOG, right? Both Indian women, Indian genetic pool, but they're going to get these guidelines. Are they going to do poorly because of that? No, because they have proven that these guidelines work anywhere. Now, when you take a middle-class Indian, what separates her from the rural Indian? It's not geographic boundaries, it's economic boundaries. The same guidelines that you can use in the US or UK can be used in India. The only reason that will keep us back is if we don't have the resources. And that's why a middle-class Indian woman who goes to a private hospital will get the same guidelines, hopefully, and get the same medications and same interventions, which will be denied to a rural Indian only because of economic reasons, not because she will not do well with these protocols. The number 2 myth is if you practice evidence-based medicine, it's going to cost more. If you do these things, if you're going to do everything, follow all these data, follow this evidence, it's going to cost you more. Actually, it lowers costs. Now, just look at the simple thing, what I talked about, prophylactic antibiotics in cesarean. If you give a single dose of cefazolin, it's ₹75 for 2 grams intravenous. Whereas if you give 3 doses a day for 5 days, it's going to cost $1,175. And then you also have hidden costs. Why is India the home of superbugs, along with our super kings and our super cricket team players? Because the abuse of antibiotics in this country is out of control, okay? And we are all to blame. Remember that. Every time you write the 2nd dose and the 3rd dose and the 4th dose, remember that you're writing a death sentence for your children and your grandchildren. Because now what is happening, people who never die, who we thought Steph and Staph was gone from this world, okay? Our children and our grandchildren are dying of strep infections and staph infections. So we have to think very, very hard before we break these rules. Let's look at uterine wound closure in cesarean section. Compare 1-0 chromic catgut versus 1-0 Vicryl. Suddenly, for some reason, about a decade ago, everybody switched to Vicryl from chromic catgut, and I said, why? It's worked fabulously till now. Why should we all change to Vicryl? Because we're talking about costs. We're talking about 130 rupees versus 530 rupees. Why should I change? So in our hospital, we took a decision not to change because we were not having uterine infections, we were not having endometritis, we were not having problems. And now the coroner's trial, which was done in developing countries, clearly showed that the use of chromic catgut versus polyglactin 910 showed no evidence of adverse pregnancy outcomes in a subsequent pregnancy, right? So if you strongly believe that certain things exist, somewhere along the line, the data will come up to validate what you're doing. Let's take recurrent pregnancy loss and progesterone. I'm a progesterone nihilist, as all of you know who have attended all my conferences. The PROMISE trial was such a validation of all that I hold dear. They showed that progesterone supplements, of course, they used only vaginal progesterone. They showed that progesterone supplements, micronized progesterone, in the first trimester of pregnancy do not improve outcomes in women with a history of unexplained recurrent miscarriages. The problem with recurrent miscarriages is that we want to be seen to be doing something. So it's very, very tempting to go ahead and give this progesterone and say, look, you know what, I'm going to do something for you. I'm going to help you out. I'm going to give you this magic pill, okay? So to hold back and say, you know what, there's really nothing much we can do if you don't have a treatable cause, but since you have no treatable cause, you're going to go through with this pregnancy. Give them TLC. That's going to take them to a full pregnancy. The cost for an unnecessary intervention, it's not cheap. Micronized progesterone, if you give it at the dose that it's supposed to be given at, 400 milligrams, is going to cost 15,000 rupees for 6 months. 21-year-old girl, married yesterday, got pregnant today, and she's put on micronized progesterone. Okay, and her husband drives an auto rickshaw. How can they afford 15,000 rupees? Please do not write these prescriptions. It's absolutely unnecessary. Okay? So, do geographic boundaries apply? In certain situations, yes. the decision has to be more made about, is it locally applicable? Does benefit justify the cost? Preeti just gave a talk about anti-D administration at 28 to 34 weeks gestation. A single postpartum dose versus antenatal and postnatal dose. A single postpartum dose will cost 2,700 rupees. If you give it both antenatally and postnatally, is going to cost 400 rupees. The postpartum dose is absolutely justified. Your chances of getting isoimmunization is going to go from 10% to 1%. But taking it from 1% to 0.1% is gilding the lily in our country. The NHS does not NHS provides free anti-D. In our country, it's out-of-pocket payment for 80% of our of society. Okay, so we can't afford to make them pay this much. And again, so in our practice, we never gave it. Systematic review, the Cochrane database looked at it in September 2015 and said anti-D administration in pregnancy for preventing Rh alloys immunization has no benefit at all. Okay? So for some reason, when it's expensive, Indian doctors tend to jump on that intervention. I don't want to be crude, but the fact that a 2,700 rupee injection to the doctor may be only 1,700 rupees, and then it's 2,700 rupees to the patient. I don't know if it has any effect on the reason that we jump on 2 injections. I don't know. But still, we have to think very carefully. So there's no benefit in giving it. Again, the reproductive health library said, at present, there is insufficient evidence of the likely benefit of routine antepartum anti-D prophylaxis in improving maternal or neonatal outcomes in current or subsequent pregnancy. So if you've been giving it, please back away from it. Again, decision, locally applicable, does benefit justify the cost? Those of you who came to Progress last month, Vincenzo Bergella said that we should be doing universal cervical length measurements to prevent preterm birth. So you should be doing cervical length measurements on all women. Now, in India, think about it. India is #1 for preterm deliveries. Okay, it's #1 in the world. But we have 26 million deliveries annually. That's what Evita said very sweetly. She said, we are delivering 1 Sri Lanka every year, the population of Sri Lanka every year. Is it possible for us to go ahead and do cervical length measurements for all these women? The reason that we have such a high rate of preterm delivery is not because we're not doing cervical length measurements, it's because we have poor antenatal care, we have malnourished women, we have so many other social factors which are leading to preterm deliveries, rather than just not doing this. So we have to think, am I going to do universal cervical length measurements? No. If a woman has had a preterm birth before, yes. Okay? We all have practices which have so many patients. We can't be caught up with doing cervical length measurements when we're still not very sure about what prevents preterm birth in these women, even if you make that decision. So we have to rethink this recommendation for our population. People say, how does it help? Does medico-legal issues, does practicing EBM help or hinder? They'll say, oh, you used American guidelines. Oh, you used British guidelines. Will that make a difference? It's been clearly shown that quoting accepted guidelines and documenting that they were followed. Please remember, it must be documented, documented, documented. If you document that they were followed, it's a major reason for rulings in the doctor's favor. Okay? So please do it. Occasionally, geography and evidence collide. And in this in India, where it has a major problem has occurred is cesarean section rates. We have been, WHO clearly says that if a cesarean section higher than 10 to 15%, there is no association with reduction in maternal and newborn mortality rates. Now, 10 to 15%, that boat sailed long ago. Okay, I don't think anywhere in the world are we going to come back down to 10 to 15%. It's not going to happen. But the problem with cesarean sections in India is not only, yes, we all worry about the fact that they are too high in certain places, but what is more worrisome is that it's too low in certain situations where we are not saving mothers' lives because the cesarean section rate is too low. Bihar, this particular data. In Bihar, private hospitals, 31.7% cesarean section rate. In public facilities, 2.6%. You know mothers are dying because they are not getting the cesareans that they require. Okay, so sometimes it's too low. In Tamil Nadu, the state I come from, in the public sector, 1 in 3 women get a cesarean. In the private sector, 1 in 2 women are getting cesareans. And I will not even talk about Kerala. Public and private, the cesarean section rates are horrendously high. Kerala is the Brazil of India. Okay? I saw a statistic, Alappuzha public hospital, one particular public hospital, cesarean section rate is 80%. Out of control. Okay, so we have to be very, very careful because the public has woken up. Subarna Ghosh has taken this through change.org. She's has got something like 1.5 lakh signatures on her petition, says it, make it mandatory for all hospitals to declare the number of cesarean sections, deliveries. She says women are being forced. This is violence against women. And what has happened because of that? Menaka Gandhi brought this name and shame thing. She said, let's name the doctors who are doing too many cesarean sections, right? And then the doctors were so horrified. They said, how can they do it? How can they say this? And how do we deserve this? We don't deserve this. We're doing this to save lives. But this is the reaction of the public. Hospitals should not make a business of doing cesarean cases. I've just taken it directly from online comments and cut the body of mothers in lure of money. Unethical doctors are not fit to be doctors. They should stop their unethical hospital and clinical business. It's becoming a money-making mode. Their license should be terminated. They should start a retail shop and do business. There is huge anger out there. Okay? That's why doctors are being beaten up, doctors are being assaulted, doctors are being kidnapped. Somebody was kidnapped in Uttar Pradesh because they said, you give us back the money, otherwise we won't release him. So I'm not saying that's the right way to go about it, but there is so much anger out there, okay? So we have to audit our cesarean sections. It must be perceived by ourselves as necessary. From the day I started, we audited our cesareans and we are a small hospital, every month and every year. It must be a part of clinical processes and protocols. And in 2015, WHO recommended Robson classification as the best audit tool for cesarean sections. And you know the Robson criteria. I'm not going to go through this, but number 1, the nullipara, singleton, cephalic, who's crossed 37 weeks, spontaneous labor, those rates should be very low. Multiparas, spontaneous labor should be, the cesarean section rates should be very low. I love Fernandez Hospital, Kameshwari, you're from there, and they are one of the only 2 hospitals, I don't know if more hospitals have started putting them online. It takes a lot of guts, but people appreciate it because they say you are being honest, okay? Whatever your numbers, you're being honest. And then it also gives you a reason to bring down your numbers. They put it up every month. So why do we need evidence-based medicine for clinical decision-making? It's so important because it gives you something to hang your hat on, something to say, we follow this protocol. Remember that practicing evidence-based medicine does not do away with complications, it will reduce your complications. It will not do away with your perinatal mortality or maternal mortality, but it will help you reduce it. It will not prevent you from being sued, but it will give you a reason to come out of it clear because you have what you have done has a basis in knowledge, in data, in global ethics, and global evidence. So evidence-based medicine, what it does is it helps you learn the language of scientific rigor. Now remember, as I said, in India, we have a very poor research culture. We don't know how to read papers. And ultimately, we don't necessarily have to. Go to guidelines, go to commentaries, go to places where they have told you this is what you need to do, okay? And then you start practicing that. And you have to learn to interpret data to improve outcome, because ultimately, as good doctors, what is our aim? Improve our outcomes, send home a happy mother, send home a healthy baby. So Again, do geographic boundaries apply? The answer is no, clearly no. What is important to remember, that optimal treatment may be global. What we have to do is we have to optimize our treatment, our interventions based on our resources, and that depends on what your local facilities are. Thank you very much.
The topic is pelvic reconstructive surgery for nulliparous prolapse. I must say that I'm a little diffident talking about this in Kerala when there are such senior professors around, because we all know that the number of cases that you must have dealt with and the experience that you people have in management of prolapse is probably unparalleled. However, I will see what the current recommendations for the management of pelvic reconstructive surgery or current recommendation for the management of nulliparous prolapse are. I start with a case of a 24-year-old student who presented with the mass descending per vaginum. She had no other symptoms. She was thin-built, BMI was 19. The cervix was seen outside the introitus. There was moderate cystocele, enterocele, no rectocele. I'm not giving you a pop Q. Uterocervical length was 8 centimeter, normal, and no neurological abnormality was found. And this is the picture. You can see that it's the usual prolapse, not really popping out entirely, but it's just the 3rd degree. Now here is a 28-year-old lady, para 1, living 1. Normal vaginal delivery of a 2.5 kg baby 2 years earlier. So it is not a big baby, nothing to suggest that she could have had a difficulty during her delivery. Presented with the mass descending, no associated symptoms again. BMI was 27. Cervix was seen outside the introitus, was hypertrophic. The cervix below the level of the bladder sulcus was 4 inches in length. There was no cystocele or enterocele, and perineal body was intact, and this is the one. Both these are prolapses in young women, and you can see the difference, and you can now kind of guess what the difference in the management would be for these two women. Prolapse in young women occurs in 1.5 to 2%. Actually, in India, people have even quoted 5%. The term nulliparous prolapse is not universally. Except for Indian references, you don't find this terminology used anywhere at all. And if you say nulliparous prolapse and Google it, it's only references from here. So they just call it prolapse in young women. When used, it refers to prolapse in young women not due to obstetric trauma or postmenopausal estrogen deficiency. So this is just not precipitated by any of this. Prolapse in young women can occur in nullipara, or sometimes in women with 1 or 2 children. Uterine preservation is obviously mandatory and all. And hypertrophic elongation of the vaginal portion of the cervix, which used to be referred to as infravaginal, and now we call it a vaginal because it's not below the level of the vagina that we are talking about, is an important differential diagnosis, which is what you saw in the second case that I actually put up. It's a long cervix, basically, of course interpreted as prolapse, and has to be managed quite similarly. Now, what is the etiology of this so-called nulliparous prolapse? Congenital weakness of the connective tissue and supports of the uterus. I mean, everyone agrees that that is what precipitates prolapse in such young women who are 20, 25 or even 30 and who are not multipara. And neurological diseases should certainly be ruled out, especially those affecting the spine, and chronic increase in intra-abdominal pressure may contribute. So we are looking at, when you say nulliparous prolapse, we are basically looking at a group of these young women or young girls who are very thin built, who you can actually make out that they really have, when you examine them, that the tissues are very weak, and they have this, what we used to call a general prolapse, meaning not strong ligaments, the uterus is down, there's a cystocele, there's anterior and posterior vaginal prolapse, and it's just a whole thing coming down, and that is the presentation of a nulliparous prolapse normally, and that's not we're talking about now. The surgical, when we go down to the surgical management straight away, the considerations here are restoration of anatomy to normal, obviously, relief of symptoms, which is basically the, whatever is coming down for vaginum, and There should be no interference with conception, pregnancy or delivery. So it should not reduce her fertility, it should not interfere with pregnancy. Most of the time during pregnancy, the problems are preterm labors, recurrent miscarriages and cervical dystocia, or delivery, prevention of recurrence. So all these must be taken into consideration when you plan management. Uterus must be preserved. All components of prolapse must be corrected. Mesh and non-absorbable sutures may be required in many of these. So even though mesh is kind of out, or more or less out, when we come to the management of the usual run-of-the-mill prolapse in the older women, this is one situation. I think a lot of people use tapes and meshes because the tissue itself is not strong enough to keep the uterus in place. Now, preoperative evaluation consists of the general examination to look for features of connective tissue weakness, obesity and other predisposing factors, degree of prolapse as assessed by the POPQ. Apical, anterior, posterior wall prolapse should always be looked for, cervical length and tone, and especially the length of the cervix below the level of the bladder sulcus to know whether there is a vaginal elongation, and the tone of the levator muscle should be assessed, because that gives you an idea of in general the tone of the, indirectly gives you an idea of what the connective tissues or ligaments are likely to be. Preoperative counseling is extremely important because many women following surgery, whether it is abdominal or vaginal, develop some amount of sexual dysfunction and dyspareunia. Even following a Fothergill's or anterior or posterior repair, they can develop dyspareunia and sexual dysfunction, and these are important in these women. Mesh related complications, if you are using those, subfertility, especially if you have amputated the cervix, the cervical factor, various other problems are there. Obstetric complications, as I alluded to, miscarriage, preterm labor and dystocia. Recurrence rates, because there is, I mean, you're doing that 20 years of age and then they're going to go through pregnancy and delivery and whatever, and most surgeries are associated with some amount of recurrence and development of urinary incontinence, which was actually not present earlier. Many of them develop that after surgery. So all these must be discussed with the patient before you take them up for surgery. So what are the options available for pelvic reconstructive surgery in the nulliparous or a young woman? Vaginal procedures and abdominal procedures, obviously. The vaginal procedures are the Fothergill's or the Manchester, which all of us have been doing for ages, uterosacral suspension and sacrospinous fixation. And the abdominal procedures could be maybe laparotomy or laparoscopic surgery or even robotic now. Could be the usually done procedures are sacrohysteropexy or sacrocervicopexy, basically attaching either the uterus or the cervix to the sacrum. Uterosacral ligament suspension and sling operations. All these, we need to look at the merits of all these and see is there any evidence to say that one is better than the other, and what would you choose and what kind of situation. The sling operations are many, and all of them are introduced by various in India during the last few decades. We start with Shirodkar, followed by Purandare, Khanna's, and then of course there are a few more added, and proponents of those believe that those are the good surgeries. So we start with the vaginal surgery, Manchester Fothergill. I am not going to tell you the steps of the surgery because it would be basically you amputate it. This is the line of amputation. You measure the length of the cervix, and of course you also cut the parametrium or the McEnroe's ligament and bring it anterior, shorten it, bring it anteriorly and suture it and do a sturmed off suture to cover the cervix. That's about it. Of course, if there is an anterior wall vaginal wall defect, you do an anterior colporrhaphy, enteroceal correction, etc., etc. So, Fothergill is, even though it is only amputation of the cervix and shortening of the McEnroe's ligament, all of us know that we do the rest of the corrections as well, depending. And a lot of people now use even a mesh with these, because if there's a huge cystocele or a bad enterocele, there are people who combine it with some mesh procedures. It's easy to perform. Operating time is short, does not require a mesh in the original description. The outcome is pretty good immediately, and the disadvantages, main disadvantage quoted is a recurrence. Now, if there's a study of 960 patients, the recurrence rate quoted was 4.3%, but it is a study published in 1995. I did look for data subsequently, but you find that this surgery has fallen, slowly with the introduction of the mesh and the sling operations and the sacrohysteropexy. The operation, this is performed so seldom that there are no large series or trials that are available. Exact data on infertility and obstetric complications are not available, but we do know that they occur, and all studies that are published are retrospective. So, is the surgery obsolete? Because people now do not even talk about Fothergill or Manchester, or is there a place for this surgery at all in the current day gynecology? My answer would be yes. I'm sure people may differ, because in women who have an apical prolapse, that is prolapse of the cervix mainly, and maybe up to 2nd degree, I'm not talking about the whole thing being out, or a 3rd or a 4th degree, with anterior compartment defects, which can be corrected much better by a vaginal surgery than by an abdominal surgery. Whenever there is a vaginal elongation of the cervix, like the second patient, the photograph that I put up, you need to amputate the cervix and Fothergill's easily is the best surgery. Whenever the ligaments are a little strong, I think Fothergill's actually works well. I'm sure, I do hope a lot of people will agree with me on this, and I continue to do this in these kind of situations with reasonable results. Now, the next surgery is uterosacral ligament suspension or plication, where you need to approach the uterosacrals through a posterior colpotomy, put them together by a stitch, and then also the cardinal ligaments. You bring them anteriorly and you plicate the uterosacrals posteriorly and refix it to the cervix. Very simple. You need to make a colpotomy incision. You need to open the anterior peritoneum, approximate posteriorly uterosacrals, anteriorly the cardinal ligaments, and hope that these will keep the uterus in place. Follow-up data limited, small series, failure rate is 15%, complication rate is 20% according to a publication in 2012, and due to poor results and fewer trials, this procedure is not used very often, though it sounds extremely simple. So then what do we have? The other vaginal procedure is sacrospinous hysteropexy. I'm sure all of you know that. Basically, it's done on one side, that's on the right side. If you pull up the uterus and fix it to both the sacrospinous ligaments, it could actually cause kinking and pressure on the rectum. And uterosacral ligaments or the cervix may be attached. It's done exactly the way you do it for a vault prolapse. Go extraperitoneally, get at the uterosacral ligament, and use a stitch to attach it to the posterior surface of the cervix or the body or at the isthmus. Can be combined with anterior and posterior repair. 6% recurrence at 22 months in a publication in 2007. The Dietz and Associates have done a lot of work on sacrospinous colpopexy. Cervical elongation and stage 3 or 4 prolapses are risk factors for recurrence. So, if you have some person with a long cervix and somebody with a stage 3 or 4 nulliparous prolapse, I think it's much better to go in for either a Fothergill Manchester if the cervix is long, or one of the abdominal procedures. But this works very well. The vaginal sacrospinous fixation works when the prolapse is only a 2nd degree and can be easily done. Okay, so this is the sacrospinous hysteropexy, wherein this posterior aspect of the cervix is actually stitched to the sacrospinous ligament. Anterior and posterior, either plication of those pubovacical, cervical or rectovaginal fascia, or a mesh repair can be done depending on the degree of anterior or posterior wall defect. The complications of these surgeries are dyspareunia, sexual dysfunction. Pain in the gluteal region is very common after a sacrospinous hysteropexy, hematoma formation, but these rates, the complication rates are not too high and are acceptable. So, sacrospinous hysteropexy has been established as effective and long-lasting procedure. Mesh hysteropexy, trachelectomy are modifications to reduce recurrence rates. No randomized controlled trial. There is no head-to-head comparison of one kind of surgery with another, and so all are small series and just observational studies published by people. Now, moving on to abdominal approach. Abdominal sacral hysteropexy obviously is the first one, and that's the one that everybody uses and is widely talked about. The isthmus or the cervix is attached to the sacrum using non-absorbable monofilament mesh. Now, the size, shape, material and site of attachment of the mesh are variable, because people use all kinds of meshes and then they cut it in various shapes and sizes. They bring it anteriorly, they bring it posteriorly, they fix peritoneally, etc., etc. But what actually the most commonly used one is a Y-shaped mesh attached to the anterior and posterior surface of the cervix. I'm sure all of you know, and therefore I'm not really describing it or putting up a video. Can also be done laparoscopically, and I think that's the most popular now. So if you actually look at it, it's a Y-shaped mesh. Cut it in the shape of a Y. This is while doing the procedure, we took this picture. So you attach one end to the sacrum, or rather you attach it to the cervix anteriorly and posteriorly and take it to the sacrum. There are people who use one Y and bring it anteriorly, take it behind the uterus, bring it anteriorly, and actually just hug or encircle the cervix and fix it, and take another rectangular mesh and use it for the posterior uterine surface. So those are also done. So it will be one Y and a one rectangular mesh. All these are done, and this basically is a sacrohysteropexy. Most studies again on this are retrospective. They compare it only with hysterectomy. Now, if you look at randomized trials, there are several. I mean, they're not randomized, but comparisons. But then you find that they've compared sacrohysteropexy with hysterectomy and vault attachment to the sacrum, or vaginal hysterectomy and reconstructive surgery, and then say that this is better. Or that is not what we are looking at. If you actually look for the management of prolapse in young women, is sacrohysteropexy better than all the other surgeries? There is no randomized control trial to tell you whether it is or not, but systematic review of retrospective studies reveal good outcome and only a 3 to 5% recurrence. Small prospective studies actually have similar outcomes and low rate of mesh complications compared to those who've had a hysterectomy. So if you do a hysterectomy and put in this mesh, actually you have much more mesh related complications. Good pregnancy outcomes have been reported. Laparoscopic approach has similar outcomes and low complication rates. So sacral hysteroscopy has become the standard of care in many centers for young women with prolapse. Laparoscopy surgery, remember, requires skill. And if you actually look at outcome of laparoscopically performed sacrohysteropexy versus open sacrohysteropexy, the results are similar except for the scar. So unless you are a good laparoscopic surgeon who can actually do this, I think you should not undertake to do it, because the results are quite similar. Laparoscopic uterosacral ligament suspension approximated, and that is the uterosacral ligament suspension. These uterosacrals are approximated and used to pull the uterus up. Very few small series and no randomized trials. We move on to sling operations, which have all been introduced, as I said, by the various well-known Indian surgeons. Shirotka's posterior sling, we all know what it is. Just take a look. This basically is where the tape is fixed to the posterior aspect of the cervix and then taken and fixed to the sacrum, and there is this big drama on the left side. You need to have the loop, and just like the original Shirotka stitch, and this is a major issue. Because you have the colon, the descending colon, sigmoid colon, and also you need to protect the ureter, and therefore that has always to be done. And so Mercelin tape is used, anatomically correct but technically difficult because of the problems on the left. You need to use a psoas loop, sigmoid mesentery is a problem, ureteric injury is a problem. No randomized trials, seldom used now, even though it was popular once upon a time. The next popular one is, especially in India, is a Purandare sling, which all of us have used, or at least I have used pretty often. Anterior surface of the cervix attached to the anterior abdominal wall using the rectus sheath. So you make a fan and steel or whatever incision, make a strip out of the rectus muscle, take it down at the lateral ends of the incision, take it through between the broad ligament and fix it. It's a very simple surgery, easy to perform. Results are very good. Again, no randomized trials. Risk of enterocele is higher because cervix is pulled up anteriorly. You could combine it with the Moskowitz, and it is used in many centers. This is a Purandare sling. Looks very, very simple. And it's actually very simple to perform because you're fixing it to the anterior abdominal wall. Then came the Khannas, wherein he decided to fix it to the anterior superior iliac spines. Very, very slight modification from here. Use a Merslin tape instead of the fascia and fix the anterior surface of the cervix to the anterior surface of the cervix to the anterior superior iliac spine. Again, easy to perform, can be performed laparoscopically, and the good results in small series have been good, but no randomized trial. So this is basically the three slings. Purandare's is anterior, Shirotka's is posterior, Khanna's is lateral. That is all there is to it. And Sunavla's, Joshi's and Virkud's are all slings that have been introduced in subsequent years, and each of them are slightly different from the other, but really no large series to say whether any of them is actually good. Used by a few, no large series, and results are difficult to reproduce. So with so many options available, how do we select the procedure? Now, vaginal approach with or without mesh are very easy to perform, vaginal surgeries, especially Fothergill's or Manchester, and of course the sacrospinous fixation. Fothergill surgery, though not standard of care, has good results in selected women. So here the choice of the patient is important. You need to choose those with long cervix and with strong ligaments. Abdominal sacrohysteropexy is the most accepted surgical procedure and is considered the standard of care. Laparoscopic approach requires technical expertise, but open method can be used with some training. Slings, especially Purandare's and Khanna's, are easy to perform, complications are very few, and yield good results, and therefore are good options to be considered. Thank you for your patience and attention.
Dr. Jayakrishnan, thank you very much, and you and your chairpersons for doing me the great honor of asking me to give this oration, which I'm delighted to do. I've been very grateful to Dr. Jayakrishnan for all the excellent arrangements he's made for me to be here on this occasion. I was slightly taken aback when he asked me to talk about this particular topic, and it's a little bit different to what you've been getting so far today. Now, one of the things that occurred to me is that my bottom was getting a little bit numb after an hour and 3/4, and it's considered to be good educational practice to get people to move around a little bit after. So anybody would like to stand up and just sort of exercise for a moment? I know this is a bit undignified for an orator, but I'm just trying to follow best practice, you understand, educational theory. Nobody? You're all too polite. Anyway, as I said, this is going to be slightly unusual perhaps for some of you, but what it marks is a change in the philosophy of medical practice. We've been talking earlier about doctors changing from being people who told patients what to do to people being with the patient and helping them to choose the right option for their own particular circumstances. And of course, this has been partly brought about because if you go back 100 years, doctors had to pretend they knew everything, and they had to be very authoritative, and they had to tell people what to do, because actually nothing much worked, okay? And the only thing we had was the placebo effect and encouragement and reassurance. But now actually we have some very good medicine, which does work, and there are real alternatives between various modes of practice which we have to help our patients choose. And along with the ability to actually change people's lives and do things which work, comes the concept that actually it's no longer possible for one doctor to know everything, to do everything, to be everything to all patients. It's not possible. And increasingly, we work in teams. So for the last 20 years, I've been specializing in looking after women with heart disease in pregnancy. In fact, for the last 10 years, they're the only sort of women I've seen. They often need critical care. But that is not something that I can provide on my own, the correct care. So for the last 10 years, I've always had with me another senior obstetrician, a cardiologist, and an anaesthetist at every consultation. Now that may seem expensive, but I have to tell you that getting it wrong is even more expensive. And it's great because we learn from one another, we support one another, we catch one another's mistakes. Did you really mean to say that, Professor Steer? Oh, yes, you're right. I got it slightly wrong. So what I'm actually going to talk to you about is in a way as much to do with team care and team dynamics and team working as critical care, because actually you can't have one without the other. And critical care isn't really any different from ordinary care, except that you need to get it right, you need to get it right quickly, and you need to work with other people. So, the first role of the obstetrician is you have to recognize the need for critical care. When does somebody can have ordinary care, or when do we need to start bringing in this team to give them extra specialized care? And of course, we do this in the standard way that we always have done for hundreds of years. We take a history, we do an examination, we do special investigations. But there's something important that I need to say at this point. When you're considering doing this, don't just take it on trust what somebody's told you. In a critical situation, it's very important that you actually check this out yourself, because the problems of getting it wrong are so great. We have to get it right. So, don't accept what other people tell you. Always evaluate the situation for yourself. And I'm sure those of us with lots of experience, sometimes what Oscar Wilde called the mistakes we make is what we call our experience. We know that actually it's so important. And just to give an example, many times I was called in because there was a massive obstetric hemorrhage. I didn't exceed the speed limit when I was driving to the hospital, because explaining what was happening to the police took up a lot more time than just keeping to the speed limit, okay? The next thing is, I might have rushed a little bit from the car park, but when I got to within 100 meters of the operating theatre, I always stopped and I walked very slowly and calmly. And then I opened the door, which often had blood on the outside of the door as well as on the inside of the door. That's when you know it's really a massive obstetric hemorrhage. Because it's important that you seem calm, that you seem authoritative, and that you seem in control of yourself. Because the worst thing that you can do in a critical situation is panic. And other people may already be panicking. And the last thing they want is a senior person to come in and panic. So I used to go into the room very calmly and say, right, I need to see the notes, I need to look at what's been happening so far, and somebody needs to give me a very clear account of where we're at. And they say, quick, 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 quick. And I say, no, if we do things now, knee-jerk, we'll get it wrong. And this patient needs us to get it right. And I cannot get it right until I know exactly what's going on, and that means looking at the notes. And I can't tell you how many times I was so grateful that that was the right thing to do. Okay. So, once we've sat down and we've carefully evaluated the situation for ourselves, we then are able to define the level of care that we need. And it may turn out that actually the bleeding's now stopped, and it wasn't so great after all, and the mother's wondering, looking around saying, I wonder what all the fuss was. And actually, when you reevaluate the situation, you don't need critical care. So that's an important decision to make, because otherwise you're going to admit a lot of people into your intensive care unit, and then it gets full, and the people who really need it can't get in. So some women will need to be transferred to normal ward care. But we must always bear in mind the risk of deterioration. So if you send someone to the ward, don't just say, oh, they're fine, they can go to the ward. You need to say, but this has happened. Please keep a very careful eye on this patient, and this might need to be done. So I want the blood pressure taken every 15 minutes, and I want the pulse rate evaluated and so on. And I'll come later to Muse charts, which we use. And it's also important not just to say, do that, but you need to say to people what to do if they're abnormal. So if you say, if the blood pressure goes below 90/50, you call me. Or if the pulse rate goes above 120, you call me. And you might think, well, shouldn't they know that? And the answer is, well, they might, but on the other hand, they might not. And I always remember being very worried about an antenatal tracing in somebody who'd got quite bad hypertension. And I said to the midwife, I'm not quite sure about this tracing. Can you put the monitor back on? And then suddenly, about an hour and a half, because I'd been, oh, what's happened? I better go back and check. And when I went back, the tracing had been terrible for the whole 1.5 hours. And I said, but I told you to put the monitor back on. And the midwife said, yes, and I did. But you didn't tell me I should do anything about it if it became abnormal. And then I realized the fault was not the midwife's, it was mine. I had not given specifically enough specificity in my instructions.
So you not only have to say, take the blood pressure, but you also need to give very clear written instructions about what to do if the blood pressure gets outside the range that you're happy with. Okay, now this may seem very simple, but I can tell you that this is the sort of thing that gets forgotten, and that's when mistakes happen and patients die. You need to consider the next level, so we're talking about level 3 care, and this is where you need to institute invasive monitoring. So it might be an arterial line, it might be pulse oximetry or whatever. But if you're considering just one organ, so it might be postpartum hemorrhage, not respiratory, then that's level 3. Level 4 is when we get on to ventilating patients. Now, on our labour ward at the Chelsea in Westminster, we have a high dependency unit where women we're concerned about will go, either fulminating preeclampsia or a major obstetric hemorrhage and so on. It's called the Simpson unit. And I was very privileged when it was opened about 10 years ago to be invited to actually conduct the opening ceremony, and there's a picture of me on the wall. And the reason I got that honour was because I'd spent about 10 years previously persuading the hospital management that this investment was necessary. Okay? And so if you haven't got such a unit, I would encourage you to do that, to get one. So it's a high dependency unit. We don't call it an intensive care unit because the definition of intensive care is that the patient requires ventilation, and we took a deliberate view that we didn't want to go that far. If the woman needs ventilation, she goes to the general intensive care unit where there are super specialists. So immediately we're thinking about, as an obstetrician, with our obstetric anaesthetists and our obstetric physicians, we're happy to look after someone in level 3 care in our own dedicated maternity high dependency unit. If they need mechanical ventilation, then that's level 4, and you need the specialist intensivists, as well as just the people I've mentioned. So in order to get all this arranged, of course, you need to assemble and organize the multidisciplinary team. And that's the next thing that you as a leader have to do in this situation. You have to decide who is needed to look after this woman. And so in level 4 care, we need the intensivist. And your job is to ring the intensivist and give them a clear description of exactly what the problem is and explain why you think their involvement is necessary. For a start, in our hospital, if you don't do that, they won't accept the patient anyway. But you should be doing that as good practice. Now, you then need to pass on the correct information to the team that's taking over care, in which you're going to be involved, but you won't necessarily always be the leader on all occasions. And for this, we need to use the approach that's called SBAR. Now, who in the audience is familiar with SBAR? Can you raise your hands? Okay, so one person is here. Right, so this talk has been of some use anyway, because I'm introducing you to these concepts, which are now very current, both in the UK and the USA in terms of critical care. And if you want to look at the details, you can go to this website, the NHS Institute for Innovation and Improvement, Safer Care. And there's the website. And you can see that what SBAR stands for is situation, background, assessment, and recommendation. So what it's doing is systematizing the approach that I've already tried to outline to you as common sense practice. But this is actually saying, okay, if it's common sense, let's systematize it, and then we can teach it to people so that they don't miss a bit out by mistake. It's actually systematized. So, SBAR, define the situation. That's what the S stands for. This is something that we must always do. It's very easy when you get senior to think, everybody knows who I am, why should I say who I am? And the answer is because you lead by example. And if you don't say who you are, then the juniors won't say who they are, and the whole thing doesn't get off the ground. And I can remember a very senior colleague of mine who was at a meeting, and the meeting was being chaired by the president of the Royal Society. And he said, I would like anyone who wishes to speak to introduce themselves to the rest of the audience. He then went on to introduce himself, as though anybody needed, but he did it. But one of my senior obstetric colleagues put his hand up to ask a question and didn't say who he was. And you know what? The president of the Royal Society said, stop, I'm not going to allow you to speak until you tell everyone who you are. And just because this guy appeared a lot on television, he was very proud and didn't want to, so he was forced to cooperate. So it's very important that we set an example. Okay, so you say, right, we're here to discuss this patient's care. I am Philip Steer, I'm the obstetrician, I'm the one who delivered the lady, or whatever. Okay, very important. May seem simple, but this is the groundwork on which successful team operations are built. And then you need to say, and we are taking this woman to the intensive care unit on the 3rd floor, or wherever. You need to be specific about where you want this person to go. And you need to identify the woman carefully by name, full name, and preferably also by hospital number. And I say this once because I had this unfortunate experience. I was sitting at the ward, and the consultant microbiologist rang me up and said, we've discovered this lady has got a positive syphilis test, and she needs urgent treatment. And her name was Mrs. Sunita Patel. And I saw some notes, and there was a Mrs. Sunita Patel, so I went to tell her that we were going to give her some penicillin. And then when I came back, I rang him back again and said, you know, can you send me a copy of the report? And as soon as he faxed it up, I realized to my horror that the hospital number was wrong, and there was another Sunita Patel in the ward. And I can tell you how big I felt having to go and say to the first lady, the bad news is I got it wrong. The good news is you don't need the penicillin, okay? So, you know, that is such a silly mistake. And one of the things you can do is you can say, you're Mrs. Patel, aren't you? And she says, yes, because sometimes Indian ladies are very polite and they don't like to say no. So instead you say, please, can you tell me your name? Okay, and then you look up the hospital. You make sure they're the right patient. It's really, really important. And medico-legally, these things go wrong sometimes. So the next thing is when you're defining the situation, you have to say what you're concerned about. Be specific. What exactly is the problem? Now, all of this actually overlaps with checklists. I was very privileged earlier in the year when I was, because I'm also an honorary professor at Cape Town University, and I met Atul Gawande there at a big meeting, and we had an interesting discussion. He was interested in checklists and developing the idea of checklists because he wanted to reduce surgical mortality. And we know that the introduction of checklists in surgery in some places has reduced mortality by 40%. The reason I'm interested in checklists is my father taught pilots for British Airways for 25 years, and I grew up with checklists. And I even have checklists on my phone for when I leave home, for when I'm going to the office or whatever. And if I don't look on my checklist, I always forget something when I'm leaving. I leave my keys behind or something. So I promise you checklists can be really, really useful in your life as well as in medicine. Okay, that's S. B for background. Describe the nature of the problem. That's what background means. Is it bleeding? Is it hypertension? Is it epilepsy? Is it diabetes? Whatever it is, be specific. Describe it. Explain any significant past medical history. Don't just say it's all in the notes. Rehearse it so that you know that everybody has not missed out anything important. Because they may not have time to sit down and read the notes thoroughly, especially if they're thick notes. They need a guide to what the key areas are that they've got to look at. So it will include things like diagnosis, date of admission, etc. you can read. So make sure that they really understand the background. So that's S, that's B. Now you need to make a recommendation. You need to say what you think should be happening. And you, as a senior obstetrician, you're entitled to your view. Other people may have different ideas. The anaesthetist may have a different idea. The intensivist may have a different idea. But you need to say what you think because you're bringing your unique perspective. I worked for 20 years with Professor Michael Gatzoulis, who's a cardiologist. And I always have to remind myself that however many women I've seen with heart disease, I am not a cardiologist. And from time to time, he doesn't object. I remind him when he says something, you're not an obstetrician, you're a cardiologist. It's very important we don't overstep our competence and take other people's work for granted. So you need to explain what is needed and be specific. I've already explained the need for being specific. Don't just do the CTG, but go and look at it, and if it's abnormal, ring me, okay? Be specific. You need to say when, and you need to say who is meant to do that. Very specifically, if you just talk to a group of people and say, keep an eye on her blood pressure, they'll all say afterwards, you didn't say it was me, I thought it was them that were doing it, okay? So you need to be specific. Now, all of this may seem obvious, but it's only too easy to miss some of these key steps out if you don't systematize it. And something that I do a lot of the time, not just with my team members, but also with my patients. One of the things I discovered was a good way of making sure my heart patients got treated correctly was to train them in what the doctors need to do when they came in. And so I would say, now, just repeat back to me what I've explained to you. What have the doctors got to do when you come in? And they say, oh, well, they've got to take me through to the labour ward and give me an epidural and make sure I don't get intramuscular syntometrin. Great. Okay, that's in the notes, and if you see any of them trying to do anything different, you ring me and tell me, and I'll tell them off. So you need to be specific, get them to repeat back to you what you've told them, and then there's less chance of a misunderstanding. Really, really important. Now, communication and handover. And again, there's a lot of jargon here, but when you start thinking about it, the jargon is helpful to build your approach. And once you understand the jargon, you will see the point of it. Now, in terms of communication, the first stage that we've got is what we call the alerter. And commonly, that's a non-clinical person. My sister has just fainted and fallen on the floor. Or, I've never seen her looking like that, she's talking funny. Or, her face has suddenly started to twitch. Or, why won't she answer me when I speak to her? These are all non-clinical alerters, and they're a very important part of the system, and we have to give people permission to approach us. We need to be approachable so that people will come and tell us, you know, so-and-so's fallen on the floor in the corner and there's a lot of blood in there. Do you think you should do something about it? Quite right. And then there's the recorder and the recognizer, and that's a more professional role. That means the person who's going to immediately attend, assess that person, take the key measurements, check their blood pressure, make a note of exactly what's going on. This is the second level. And then the third level, which can be either a recognizer or a primary responder, is actually looking at those observations and saying, what do they mean? Do we need to give them a blood transfusion? Do we need to give them an anticonvulsant? Do we need to give them a hypotensive? What is it that we need to do as an immediate response to keep this patient safe? It might be we need to re-establish the airway. But this is known as the primary responder. And then you've usually got a secondary responder. In our system, this will be somebody who's been in obstetrics and training for perhaps 5 or 6 years, and they're always resident, so at all times there will be somebody of this level available in the maternity unit to be the secondary responder. And then, of course, there's us as specialists. We're the tertiary responder, and we get called in then to work out the next stage in the process. So this is the technical way that we describe this system. Now, I'm going to say a few words about situational awareness. Who's familiar with the term situational awareness? Really? Surely there must be one or two. Okay, because this has become a very important issue, and I'm going to describe the key components of situational awareness for you. It's the ability to identify, process, that means work out what it means, and comprehend the critical elements of information about what's happening to the team. Now, that's sort of jargon, okay? What it means is you've got to know what's going on around you and not just focus narrowly on the patient, but is there any blood in the fridge? How many staff have we got? How far is it to the intensive care unit? This is situational awareness. It's looking at the bigger picture, if you like, okay? And it's very important that we don't become so focused on the immediate problem of putting up a drip that we forget to tell someone to go and order the blood. That's situational awareness, okay? So it's important to think about that. So when you're struggling to get in the cannula, I've got to get this large bore cannula in and she's got collapsed veins. Oh, but I need to make sure that somebody's gone to get the blood because no good me getting the cannula in if there's no blood. Okay. Always avoid an exclusive focus on one aspect. And this is a bit of OCD. You know, people who are a little bit Asperger's-y, and they're so keen to do a really neat venipuncture or whatever it may be that they forget about everything else, okay? So you mustn't do that. You must keep an awareness of what's going on around you. The obstetrician needs to be the team leader and coordinator, obviously, and so you need to have what's called, this is jargon again, but if you start thinking about it, you'll begin to understand, a shared mental model of where you are, what the problem is, what team members have you got around you? Who are the best people to do X, Y, and Z to make sure that you allocate the right person to the right task? If you start thinking about it logically, it works. So the task and team goals, responsibilities, individual tasks, and then, of course, leadership. I already mentioned leadership and how important it is to be a role model, and that's something that we can all learn to do. You know, some people are born as role models, some people learn to be role models, and some people have the business of being a role model thrust upon them. But whatever it is, we can always do it better, and we can go on learning throughout our career. Now, I'm just going to describe to you some typical situations in which loss of situational awareness can occur. Okay, so let's just see what these are. People get a bit confused as to exactly what's going on because there's so much happening at once, they're not keeping their mind clear. No one watching or looking out for the hazards. Is the patient just about to fall on the floor, for example? You know, so busy putting up the drip that you forget they're rolling towards the edge of the bed or something like this. Use of improper procedures. You're actually working very hard on doing something. It's actually the wrong thing that you should be doing. Departing from guidelines. We've heard a lot about this today. It's really, really important that we try and minimize departing from guidelines. They're there for a reason. And it's to safeguard the patient. It's also to safeguard us and our reputation. Failing to meet planned targets. I need to get this drip up by. If I can't do it, the anaesthetist must have a go, or the intensivist, or somebody needs to do a cut down. There's no good saying, I'm not going to let this beat me, and 20 minutes later you're still trying to get up the large bore cannula. You know, you've got to know when to stop and let someone else take over. Unresolved discrepancies. What you're saying is different to what the midwife said happened. Ambiguity, not being clear about what you're wanting people to do. Now, all of these things sound very medical, don't they? Well, actually, I've already mentioned fixation and preoccupation. Let me show you where I got it from. It's a US Coast Guard training manual, okay? So this is any group of people in a tough situation need to be careful about their situational awareness. And don't forget that if you're trying to do something, you're on the heaving deck of a lifeboat, it's a bit different to doing it in the shore base, okay? So this is a common issue throughout all big teams. Crew resources management. Who's heard about that? Okay. Now, these are all little, oh yes, my UK colleague has heard of it. These are all things which I suggest you just jot down these headings and then look them up on the internet afterwards, because there's lots and lots and lots of this stuff, and it really does help you to be a better doctor in the acute situation, in the intensivist situation. Crew resources management actually comes from the aviation industry that I was referring to earlier. And of course, they went from having lots of planes that disappeared in the 1950s to now it's the safest mode of travel there is, and that's because they've implemented crew resource management. It was developed essentially to stop people making silly mistakes, and that's exactly the sort of systems we need to put in place more often in medicine. It's about communication, decision making, so all of these jargon phrases are coming into play here. We need to be at times assertive. In an emergency, you don't need to sit there and start having a debate about the evidence base. That's your job to know about that beforehand. You have to say, you do this, you do that, and you do the other, and then we'll get on with it. You know, there needs to be a degree of decisiveness. Once you've done your assessment, you've assessed the situation, you've done your SBAR, now this is what we need to do. Okay, let's get on with it. And just to give an example, I won't say who it is, but it's one of my trainees who's now an eminent professor somewhere else. I was a bit unhappy about how her labour was going, so I thought I'll just go in and keep an eye on the chaps, you know. And I went in to see her, and the trace was terrible. So you know what I did? I said to her, oh, well, I'm not too happy. I think the baby needs to come out now. And I disconnected the monitor, and I took the brakes off the thing, and I started wheeling her bed towards the operating theatre, okay? So everybody knew that this was an emergency and we needed to get on with it. This is known as, I didn't ask anyone's permission. I didn't ring up the theatre sister and say, can I open the theatres? I just started doing it because this is what saved the baby's life, and I now get lots of nice videos of the child every time it has its successful birthdays. So, you need to get the relevant person's attention. You need to make it clear when you're concerned about something. You need to state the problem clearly, and you need to say what you're going to do about it and reach a decision about that with your colleagues as quickly as possible. If you like, we can summarize this as dealing with red flags. And the way of remembering this is you see it, You say it, this is what I'm going to do, and then you do it, you fix it, okay? So it's a question of being decisive. Once threats have been identified, you need to say what needs to be done. Now, it's also true that what we mustn't do is override other people's opinions. We need to get all the information and opinions from teammates, and we all know the terrible cases where airliners have crashed because somebody's seen that the engine is on fire, and they go and see the pilot, and the pilot says, "Don't bother me with that, I'm too busy taking off." Okay? Sometimes the members of the team have to be assertive and say, "Did you realize that the venipuncture you just spent 10 minutes putting in, it's come out, we need to replace it?" You know, you need to give them permission to bring important things to your attention, and you must not jump on them or get cross or get upset. You have to say, "Thank you so much for telling me that the engine's on fire. That could save everybody's life." Okay, you need to be able to do that. But nonetheless, you need to make the final decision. You need to take everybody's opinion and ideally take everyone with you. That's very important. For 4.5 years, I was actually the clinical director of our level 3 neonatal unit, one of the few obstetricians who's done that. And there was a very important policy that whenever they did anything major, like withdrawing care, for example, they got everybody involved. So if you have time, get everybody involved, get everybody on board. That way you're less likely to make a mistake, because somebody should put their hand up and say, "What about X?" Does this work? Well, there are some studies, and this study from about 18 months ago actually was in Hong Kong. And they looked at 240 healthcare professionals, and they took people through a whole-day course of resource management training, and they found actually that people enjoyed having these various steps pointed out to them and developing techniques for making sure they didn't leave crucial bits out of the process. And it's very important that we value our colleagues and we involve them appropriately. It's all about team performance, and that ultimately is what ensures patient safety. Everybody has to be fulfilling their own part of the team. So simulation team training is important. You might want to remember the acronym of SAFE. Is the patient sick? Are they not sick but at risk? Do we need to have specific follow-up? And if you're sending somebody to the ward from the lay ward, you always have to remember to make a note of whether they have an epidural in sight or not. Now, once you take people into our high dependency unit, we now use standard the maternity early warning systems. Who uses maternally? Okay, so only one hand again. Okay, these have now become standard in most critical care areas in the United Kingdom, and I would say actually in many other parts of the developed world. It's a very simple system. It simply says, rather than expecting everyone to know what the normal blood pressure is, you plot it on this chart, and if it goes into the yellow bit, you should be worried, and if it goes into the red bit, you should be very afraid and call somebody very quickly. It's really just intended to simplify the process of getting the right people called in at the right time. They're called Muse charts. There are lots of them around. You find them on the internet. They can be used. They're not a substitute for knowing the right thing, but they do mean they can be helpful, particularly to the more junior members of the team who are not so familiar with the normal ranges as we might be. Finally, I'm going to talk about some more words that you may not have heard. You all know about a brief and a debrief. How many people have heard of huddles? Oh, you see, just again, 1 or 2 people. But you will hear a lot more about huddles as time goes on. Okay. So what's the brief? The Americans call it handoff, which sounds a bit offhand to me, but anyway, that's what they call it. We call it a handover. It's otherwise known as a change of shift. And then there's the debrief. And the debrief has got to be really sensitively handled. You've got to concentrate on being positive and supportive in critical situations. What went well is a good place to start, because that gets people thinking, oh, it's not all going to be about what I did wrong, okay? What went well? You put up that drip really well, and you nipped off and got the blood, and it was very efficient, and et cetera, okay? So start with what went well. Then you can say, well, there were 1 or 2 things didn't go too well. We must cover that. This is not to blame anyone, but, you know, how can we as a team do better next time? What should change? And this is perhaps the most important thing. Next time this happens, what should we do that's different? How should we change the rules or the guidelines to make sure we're more effective? Okay, I said about a huddle. What's a huddle? Okay. It's something that we've done sort of informally in the past, but it's not a bad idea to make this a formal arrangement that you can invoke. It's basically something's not quite right, and you're not quite sure what's going on or what should be done about it, and you're sitting there thinking, this is a bit bigger than just that I can deal with. Let's get the anaesthetist, we'll get the obstetric physician if they're around, let's get the senior midwife and blah, blah, blah. Let's just discuss, and I will explain to them what my concerns are, my feeling that something's not quite right. Let's see if we can sort this out, and how should we go forward. It's group responsibility. And it often is very effective in coming up with the problem and defining it and saying what you should do next. It's an important rule that anyone can bring such a meeting together, even if it's the junior midwife or a junior nurse who says, I'm not really happy with this patient's blood pressure, or they're not answering me like they did an hour ago, or they've gone a funny colour. If they're not sure, rather than just think, should I really bother them? They can call a huddle, okay? And by giving it a name, it somehow makes it official. It's something you're allowed to do, okay? So they call a huddle. Anyone who can should leave what they're doing that's not urgent and join in. So it is very much a joint activity. And you can do it at any time. It's not just a handover. And you can be amazed at how importantly decisions can be made which actually head off a developing problem early. You don't have to wait till the handover to tell someone you're worried about blogs, because that might be 2 hours later. If you're worried about somebody, tell them now. This is what the point of calling a huddle. And you can go to www.england.nhs.uk, sign up to safety, and there you've got your essential guide to huddle or not to huddle. It's rather fun, and it's something you can do when you've got a spare moment. So, coming back, I'm coming to the end of my talk. What's the obstetrician's role in critical care? Well, it's actually all about the multidisciplinary team. But as the obstetrician, we do have a particularly specific role, and that is, because it's a maternity issue, we have to initiate that multidisciplinary team involvement. And we need to motivate people to think this is an important activity and something that they enjoy and they get feedback, positive feedback from being involved in. And we need to coordinate it to make sure that everyone has their say, and there's no one bossy person that takes over the whole meeting. Everyone has to be allowed to say, and you need to get the quiet person in the corner, now come along, what do you think we should do? And sometimes you think, oh, they've spotted the weak link in our thinking. So it's really important that everybody is involved. So there's a multidisciplinary team. The obstetrician is there. I'll leave you to judge which person they are. It is a team, and enjoy your multidisciplinary teams in future. And thank you very much for giving me the honor of asking me to do the oration.
What's the best epitaph we would like for ourselves? I mean, of course, none of us ever believe that we are going to die. But when we do, what would be the best epitaph? For me, it would be a life well lived. Because I think that's extremely important, that if somebody looks at our lives and they said, she did everything, she lived well. Sometimes you have to look back in order to understand the things that lie ahead. So therefore, I'm going to walk you through certain thoughts, how to rethink, renew, and reinvent. Knowing yourself, Aristotle said, is the beginning of all wisdom, so I am going to walk you through some parts of my life. My husband and I left for the US immediately after medical school to go and do our residencies. And out of a class of 160, 90 of us went abroad for our training, and the 2 of us came back. Having a medical degree may be the ticket to a good life, we thought. It was not just the medical degree, but we had had a foreign degree now, foreign training. But we also thought, why can't we think of it not just as a ticket to the good life, but as our ticket to bring about change? We knew by then that many youngsters could not go abroad. The rules were getting stricter. there was a very strong sense in both Arjun and I that we should come back, that we were very blessed to have got that kind of training, that we should come back and give it to our own students. There was also a very strong feeling that if we were trained so well, why should I use it to treat people of another country when I could do that for my own people, for my own women? So we came back in our 30s. We were very early. We were young. My son was 10 months old. And at that time, we thought everything was going to be simple. It was going to be easy. We were going to come back and start our practice, and everything will go well. The sun was going to shine all the time. But you know, it's never that easy. Particularly having to come and face a huge change in the medical environment. Where we had trained was very different from what we had come back to. We had trained in 2 different hospitals, but state-of-the-art, extremely well-equipped. I used to say we did not go from one country to the other, we had gone from one century to another. And we came back to a small hospital, the same hospital that Arjun and I were born in, and then we slowly converted from a nursing home to a medical center. The only way we could practice medicine the way we wanted to was to adapt. There was no way we could just continue to practice the medicine that was being practiced here at that time, nor could we expect to practice the medicine that we had been trained for, but we had to adapt. The only way we could adapt was to reassess and reevaluate. We had to make sure that we could bring that kind of medicine and we could do it here. We had to be very ingenious. We had to make a lot of changes, but we realized that we could continue to practice that evidence-based medicine as long as we wanted to work very hard to make the changes. Around that time, Arjun came across William Blake's poem, and he said, "I must create a system or be enslaved by another man's. I will not reason and compare. My business is to create." We put this up on our memo board. And we said, nobody is going to hand it to us on a platter. We are going to have to change. We are going to have to change the systems. We tried to go back and join the government institutions. We offered ourselves as honorary teachers. We said, we will come, no pay, nothing. We will come and teach. But Tamil Nadu at that time was just changing the rules, and they did not want honorary doctors. So we went ahead and started teaching outside on our own. Because if they were not going to accept it, we were going to create a system where we could spread education. We also had to adapt medical care to resources. Our hospital was one of the first ones to have fetal monitoring, laparoscopies, but it was very difficult to have, I remember just to get the carbon dioxide, when we came back, we found that people were just pumping air into the peritoneal cavity. And then I tried to go and get carbon dioxide. I had to work with a factory which was producing carbon dioxide. It was not medical grade carbon dioxide. They were having these huge cylinders. I had to use something so we worked with them to ultimately filter it and bring down the pressure. But you can. If you're focused, if you're OCD, you can. There's no way of saying, oh no, it's not available, let's not do it. So you have to adapt medical care to resources, as long as you decide that you're not going to compromise on patient care. And most importantly, we were determined that we would provide affordable care. If there are very young doctors here in the audience, if you think having a delivery having a delivery cost in the thousands, at that time when I came back in 1981, a delivery in our hospital cost 250 rupees, okay? That's about 2.5 pounds. In-house training for nurses. If we wanted to provide good care for our patients, we were going to train our nurses. So we sat and used to, at the end of a very busy day, we would still have classes, we did in-house training. Who was going to come and teach them? Nobody. So we did our own training, and we introduced protocols and processes. We don't have the jargon that you use, Professor Steer. Absolutely, this is important that we name them, S-bar and all this jargon, but we did it without the names, the labels, but we insisted that we must have protocols and processes. The whole process of, one of those things that you said, you don't run when there is a problem. The rule was in the labor room, when somebody started bleeding, when somebody collapsed, everybody had to slow down. So we built in these protocols and processes because you can't expect them to do what you want unless you make it very clear, unless you teach them. We also decided that we had to go against the grain and refuse to conform. Take the road less traveled instead of the well-beaten path. When we first decided in 1981, soon after I came back, when I said we're going to have husbands in the labor room, at that time in my consulting room, mothers would come with their mothers or their grandmothers, or if nobody was around, the next door neighbor, as long as she was female. Men were not even seen in the consulting room. And so I used to say, bring the husbands. We need them here. They're here, you know. Just because he impregnated you, he does not become a hero who's got to be placed on the pedestal and he's completely cut away from the rest of this reproductive process. He's also going to be with you. And I've had mothers and mothers-in-law tell me, my son is very gentle, you know, he's a gentle person. Said, well, if she can have the baby, he can very well be there helping her have the baby. So we started having husbands in the labor room, and it was amazing, the whole process of having the husbands there. They go take the baby out, and the first time the family sees the baby is when the father goes and shows the baby out. We introduced charts. Even today, I know that most hospitals do not have charts. They don't hold on to the charts. The patient is given the obstetric chart. She carries it around, and if she does not bring it, you don't know what's happening with her, okay? So we introduced charts. We had permanent patient records. We kept the records, gynec records were kept for life. Even if she had come 25 years ago, we could pull it out. Pregnancy records, delivery notes were kept for 5 years. And we also started entering them on computers so that we could recover data. The only way you can audit your data is if you have the data, okay? We also started doing CMEs and conferences and workshops because, again, as I said, we had to create a system of our own. The regular systems did not allow us to come and teach because they said, you don't have a degree. At that time, they were not recognizing the American board. So therefore, we were basically only MBBS qualified. So we said we had to create systems. We started doing CMEs. We had a huge following. My second child came along. And as all of you know, being a mother is very, very tough if you also want to be an obstetrician, a conscientious obstetrician. So, and you know that working mothers become masters of time management. We have to work around everything in our lives, and the family work balance becomes very, very difficult because I remember when I went to pick up my daughter once when she was in kindergarten, and some other mothers were all standing around and they said, oh, Dr. Geeta. And then they turned to the child and said, so what do you want to be when you grow up? Are you going to become a doctor like your mommy? And she said, no. And I said, oh, I'm going to become a mummy. I said, what does that mean? So I'm, completely traumatized because why does my child want to become a mummy? And she said, mummies come, they're always there at home. They come and pick up their child from school. They feed, they cook, they do. So she had this image, this fantasy of this perfect mother, which I obviously was not, because I was always running away. When it was a birthday party, I was called for a delivery. So I was not the perfect mother. But what we did was, it was the hospital, the children, the hospital, the children. You have to work out. There's no parties, no other social life. When we went to speak at a conference, we dragged them along, okay? Because they were with us. That time on the train or the flight or in the hotel was time with the children. So you have to get that balance. And because, being a mother, you're supposed to be the perfect cook. the perfect office manager. You're supposed to be, you cook better than the mother-in-law. You're supposed to be just everything, and you can't. So you can't try for that, but certainly focus on your children, and I'm happy to say they've done very well. But in 1983, I took a decision that we must bring in group practice, which is not something commonly done in this country. So we asked young doctors to join us, and they had to join us as full-time registrars. They could not come just for 6 hours or 8 hours. They had to be, if they came in the morning, they started working with us when we started in the morning, and they went home and we went home. Because you can't say, oh, the patient's going to deliver, but my shift is over, I'm going, because you don't learn. Because you don't know what actually happens with that patient. So they joined us as full-time registrars. If they had worked with us for 2 years, they progressed to junior consultants, worked under supervision, and then they got an independent practice, but they continued, the patients continued to belong to the hospital. Ours was a small private hospital, remember, just a 30-bedded small hospital. It's not a fancy corporate hospital, it is not a big institution, but they all worked, and they loved to work with us because we treated them as, and it was always a teaching experience. Advantages, emergencies can be handled as a group. You don't want to be caught up 2 o'clock in the morning with a PPH and you're the only one and maybe 1 or 2 nurses. You have around-the-clock labor room coverage, and this is extremely important. The mother always has an obstetrician around. She always has somebody, sometimes 2 and sometimes 3, always nurses around. And that helped us keep our cesarean section rates low till 2013 when I retired. Our total cesarean section rate did not go beyond 22 to 25%, but not at the risk of having a higher perinatal mortality rate. Our perinatal mortality rate was the same as the West. So we had very good numbers because we did annual audits of delivery rates and PMR. Advantages also is their ongoing teaching and passing on of skills, okay? When I die, I don't want my skills to die with me. It must go on to the next generation, and they can teach more people, okay? So it was always a question of passing on the skills. My mandate to my younger doctors was, I want the patients who are coming into the hospital to say, I can't see Dr. Geeta Arjun today. Oh, that's fine. I'm happy to see you. Or to ask for you. The day they call and say, you know, I want an appointment with this doctor. I don't want an appointment with Dr. Geeta Arjun. My life is validated. Okay, I have done a good job. And that's the most important thing. And then, of course, we're mostly, as you know, obstetricians in this country are women. And we need some time off. And children are so much happier because they know that one weekend in the month you are theirs exclusively. Then I hit my 40s and I had to rethink a lot more. I said, you know, I have to do something more with my life. I had to rethink my goals. And I think all of us at every part of our life, phase of our lives, we have to rethink our goals. And sometimes we need to really sit down and figure out what we want with our lives. So in 1991, it was 10 years after I had come back, and I said, I need to do something more. So I got into maternal fetal medicine in a big way. We started doing intrauterine transfusions. We started doing all that. And so the next part of my life, the next part of my professional life started. Also, again, we were so focused on evidence-based medicine, and we would realize that when you have protocols and processes, you are able to deliver excellent medicine, and I wanted to spread that message, so I started Practical OG Congress, which started in 1993, and most of you have attended at least one progress in the past 24 years. We also held it twice in Myanmar, and that gave us a platform for teaching people practical OG. Practical, what do you do when? You know, that kind of a thing, and as you know, it's been an extremely popular conference. We also need to, all of us have to rethink our practice norms, okay? The good physician treats disease. The great physician treats the patient who has the disease. And very often we forget. Again, one of the things I used to tell my junior doctors, do not tell me room number 20's blood pressure has gone up. Because certainly room number 20 does not have high blood pressure. I want to know the name. I want to know who she is. I want you to constantly remember, visualize who that person is. When we say a name, you should visualize who that person is, okay? You treat the patient, she may, or don't come and say, oh my God, I saw a fantastic picture of a placenta previa. Hey, who's the patient? Think about her. She's got the placenta previa. You have to continuously improve patient care, and this comes from constant self-evaluation. What are our numbers? What has been going wrong? Why has it been going wrong? And it's a question, it's a commitment to lifelong learning. It's a commitment. You have to say, what I have learned when I was 30 is not enough when I was 40, it's not enough when I'm 50. You have to lifelong care has got to be there. The laboring mother. There has been so much violence against pregnant women when they are in labor. This is culturally across the world. The woman is made to feel at that point when she's in so much pain and she's screaming in pain or crying in pain that somehow it's all her fault. And this always worries me because, again, as we are all women obstetricians, it always worries me that this kind of nastiness comes from women towards women. Telling a woman, oh yeah, you enjoyed conceiving the baby, now what are you screaming for? I find that so horrifying, okay? So the laboring mother only remembers, she will forget the pain, but she may not forget how you treated her. People will forget, Maya Angelou, one of the most brilliant poets, said, people will forget what you said, people will forget what you did, but people will never forget how you made them feel. Again, in our hospital, the focus of it was when they have finished their delivery and when they're ready to go home, we asked them, was it a pleasant experience? And this was absolutely the top of my list. My doctors and my nurses were told, this must be the best experience of their life, not because they've had the baby. At the end of that, most women will forget what they went through, but the whole process, from the time they came to the time they left. Kindness is a language which, Mark Twain said this, kindness is the language which the deaf can hear and the blind can see, and the mother will always treasure. So that kindness at that particular time, being able to offer her pain relief, the ability to give her husband next to her, being there with her, giving her support, that is so important. And I'll also quickly tell you what's the other advantage of having husbands in the labor room. Women do go crazy. There is a term in Tamil called prasava vairagyam, the madness of labor, because at that point you lose a lot of your senses. And women tend to, some of them tend to scratch, some tend to bite, some tend to kick in that pain. So we just offer them their husband. We say, here, he's the one who got you into this trouble. Please, feel free. Whatever you want to do to him, feel free. Leave us out of it, okay? We are there to support you. We are there to help you and your mother, a baby. The other thing that I very strongly believe is that we have to rethink our relationship to the pharma industry. It's become very murky in this country. It's becoming worse every day, and I think we need to think about it. Because unless we do it, the government is going to do it. And when the government does it, it's going to be a very nasty situation. It's a murky relationship, and our commitment has to be the patient. And the day you take money from the pharma industry, you've sold your soul, and you will never get it back. So please remember this. Please remember this. You cannot say, oh, they're paying my delegates' fees. I'm going for an academic program. So they're helping in academics. No, they're not. They're buying you. And we know what bought women are, right? We don't want to belong to that category. In my 50s, I decided to renew a lot of things. I wanted to bring in a pregnancy guide for women in India, written by an Indian doctor, talking about Indian myths, Indian diets, Indian issues. So it had to be that way. We brought out a Tamil issue also. And then also I brought out textbooks because you have to give back. We had got so much from the obstetric community that I wanted to give back. And the last book, Essentials of Obstetrics, along with, written with Lakshmi, has now become one of the best standard textbooks for undergrads. You have to renew your oath. Remember, it was a Hippocratic oath, not the being a hypocrite, okay? So you have to go back, look at that oath again. You did take an oath, okay, to do the best for the patient. Go back, look at it, okay? Renew your knowledge. Look at the different guidelines. Keep up to date. You have to keep on updating your knowledge. Keeping up with scientific practice of medicine is extremely important. Then you adapt that evidence to practice, and then you adapt your practice to your resources. You can practice very good medicine even in low resource countries, low resource situations, because we can adapt evidence to resources. Renew your passion. Don't forget that the reason you became a doctor was that concept that you could extend a helping hand, that you could do something for somebody, you can change their lives. You know, just imagine how many of your relatives or friends come and say, oh, you know, I want to do something for society. I want to help people. And every day you sit at your desk and it's coming to you. Every day you're blessed because you're able to help somebody. Don't ever forget that, okay? That was the reason we went into medicine. And for me, another reason I love this part of it is the thrill of the chase. Like Sherlock Holmes, when somebody presents to us with a problem, we are able to go after it, solve it. For me, that is the biggest thing. I used to tell my younger doctors, once you've taken the history, and she has walked in, you've taken the history, before you go into the examining room, you should have a diagnosis and you should say, yes, this is what I'm going to find. And when that actually comes true, what a great blessing that is. We always should continue to have curiosity about medicine, and it should be intense forever and ever. Caring towards patients should be unconditional, and commitment to the profession is lifelong. Champion the patient's cause and do not follow unproven and unscientific medicine. If you're not an Ayurvedic doctor, don't write Ayurvedic medicines. In my 60s, I decided to reinvent myself. And so 2013, after 32 years of practice, I hung up my shingles. I said, you know, my husband and I are almost the same age. And he said, oh, you know what, we are 60. We may not be able to do anything much after another decade. It's not that you're going to die, but then you may not be able to do it. And I said, you know what? I need to get away from the constraints, the time constraints that medicine places on me, and we wanted to do something more. The first thing I did was I ran a marathon. At that point, this picture when I went rock climbing very clearly shows my state of mind. I was holding on, one hand was holding on to the rock, didn't want to let go, the other one had let go. So it was a tough decision. It took me a long time, a year and a half, of sadness, crying, all kinds of things. How do I abandon my patients? But there are always catalysts for change in your life, okay? And which pushes you and gives you the right reason. One of the life-changing events in my life was when my brother died at the age of 51. Brilliant surgeon, fantastic. Of course, it ripped the fabric of our lives apart. But when you look at it from the patient's point of view, people used to say, if Dr. Ravindra Padmanabhan is not there, who's going to operate on me? But he died. There were ripples on the pond, but then it became still, right? No patient said, he's not there, I'm going to die of a burst appendix. I'm not going to have surgery. And that brought a lot of things into focus. We are not indispensable. We should not buy into our own story of being the indispensable doctor who has to continue to work till 90, because what are these patients going to do without me? You know, this is a story, myth we build for ourselves, and it's not true. So you have to make the decision. Are you going to continue to be the old you, or are you going to be the new you? And I took stock of my career. I said, I've done everything I wanted to do with my career. I have no regrets. I've been a maternal fetal medicine specialist. I've done so many things. I've done oncology. I have done high risk, 40% of my patients are high risk pregnancies. I mean, done it all, written books, lectured, so it was fine. But taking the leap is tough, because when you leave that nice, comfortable fishbowl that you were in, you don't know if the next fishbowl is full of pure water or it could be acid. It is tough. And many people ask me, what will I do after retirement? You must remember, you have to plan for retirement. As we are born, so shall we die. As we are employed, so shall we retire. But the plans of retirement should be made midway in our career so that we can build up what we're going to do when we are actually don't get up in the morning and go to the hospital. Okay, you have to build up more interests, more hobbies, being ability to keep yourself occupied. Samuel Johnson said, don't think of retiring from the world until the world will be sorry that you retire. You must be so good, you have done so much that the world should be sorry that you retire. But I also say, don't put it off till the world wishes you were gone. Okay, you will all reach a stage where they'll say, oh gosh, she's back again. She should be retiring, you know, she should not be practicing. You shouldn't be in that situation. Sometimes we get onto the treadmill, you know, and then we are working hard, so hard. Of course, a lot of it is because it gives us satisfaction. But then sometimes it becomes an affliction. It becomes egocentric. Again, who will do this fantastic surgery if I don't do it? You know, you think you're the only one who can do it. And then also it becomes over-planning. I have to plan for my children, I have to plan for my grandchildren, I have to have so many houses, I have to have cars for them, we have to have money for their education. For heaven's sake, give them their education. We've told our children, we are planning to die poor. We have given you a phenomenal education, stand on your feet, and thank God they're doing extremely well. But we plan to die poor because we earned it all, we're going to spend it all. Okay, and they're quite comfortable with that. And you also have to change focus. I have gone into both national and global social impact work. So you have to change focus. You have to say, okay, what else can I do? What else shall we do? There's never enough time to do all the nothing you want. Just think about it. Aren't there days when you say, I can't go back to the hospital? How many times do I have missed sleep at nights? I have not had a full night's sleep for years and years and years, right? There's no time to do all the nothing you want. And there may never be enough time to do everything you want. How many times have you said that person died immediately after finishing surgery? I really didn't want to die that way. I didn't want to be that person who kept working to this. It's not a bad ambition to have, but I also want to do other things because there are so many other things in life that you want to do. I still find each day too short for all the thoughts I want to think, all the books I want to read and write, all the laughter I want to share, all the roads I want to walk on. At age 20, we worry about what others think of us. At age 40, we don't care what they think of us. And at age 60, we discover that they haven't been thinking of us at all, right? That's what Ann Landers said. There are several advantages to growing older. And advantage number 37, as far as I was concerned, is that you can stand in the middle of York and have your picture taken with a half-naked hunk, and nobody really cares, okay? Certain great advantages to growing older. The 4 M's of retirement, can I have 5 more minutes? I'm sorry, I think I'm running over. 4 M's of retirement: money, memory, maintaining health, and Mr. and Mrs., okay? Money, will I have enough of it? Oh, for heaven's sake, you will have enough, because you know what's going to happen when you grow old? You can't eat too much. You're going to get to the point where you cannot eat this kind of a thali. You will just be eating 2 idlis because that's all your stomach can handle. Otherwise, you'll get acidity. And sugar has been cut off because either your triglycerides are too high or you are a diabetic. Salt has been cut off because you're hypertensive. Life is not going to be very good. So, you know, you just enjoy it when you can. You don't need too much money to eat very little food and very bland food. But remember, don't make any high-risk investments. This is not the age to make that. This guy is saying, when I lose weight, I gain it right back. It's the same for losing money, right? No, 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 no. You can lose money at 30 or 40 and make it back, but at 60s, you cannot make it back. So be very careful about your money. Put them in fixed deposits. They're the best bet. And please nominate your bank accounts, FDs, and stocks, because particularly in India, when you're dead, getting it all out of the bank will take your heirs anywhere from 10 to 12 years. Okay, so be very, very careful. And write your will. Okay, I know everybody thinks, yeah, I've got enough evidence. People die. I'm not the one who's going to die, okay? I'm going to be alive forever. I'm going to be that one immortal. No, we're all going to die. We wrote our first will when we were 46, and I tell you, it took us 4 weeks to first actually start writing it. Because when you write a will, you are accepting your mortality, okay? Write your will because it's extremely important. There are a lot of things you will have to tell your children and put it away, because your children should not struggle with that because there's no will. Getting old isn't that bad, except for a little forgetfulness. All of us, okay? Nominal aphasia is my curse, okay? And my children laugh. They say, I'm going to talk to my niece, but I start off with my son's name, my daughter's name, the eldest niece, then the second niece, and then I come down to her third niece, because my mind has to go through that memory trick, unfortunately. We spend a lot of our time in our lives. 20% of the time is spent in sleeping, 20% in working, 10% in eating, and 50% looking for things you just had a minute ago. Okay? That whole joke about having your glasses on your head and looking around, we laughed our guts out seeing an old person doing it, and now we are doing it. Okay? We are in that position now. Exercising and diet, very, very, very important, because as you grow older, you need to be fitter and fitter. Eat less and exercise more, he says. That's the most ridiculous fad diet I've ever heard of, but heaven's sake, remember that whatever exercise you're doing, you're obviously doing much less than you should be. However much little you think you're eating, you're actually eating much more than you should be. Okay, keep that in mind. Maintaining equanimity is very, very important. Okay, all of you know that meditation is very important. And what is meditation basically? Keeping your mind clear. You do not, because otherwise a lot of these bad thoughts are just jumping into your head. As soon as you sit down, you think about, oh, my mother-in-law said this. Oh no, my son is not doing well in his job. Or my husband, oh gosh, he's home again and he's sitting and complaining about my cooking. So you need to meditate, you need to get to it. And there are many ways of doing. People recite a mantra, people pray, people do anything. There are several things you can do. And one of the great things for meditation is nobody really knows which actor you are thinking about, okay? So, I mean, when you have him in your mind, you really are not considering all the other problems. You're smiling, okay? That's why this lady is smiling. She's looking calm because nobody knows what she's thinking about, but her mind is peaceful. The other thing that happens with retirement is that you start spending a lot of time together. This gentleman is reassuring his wife, now that I have retired, I can use my corporate training to make everything more efficient at home. And what is she, why is she looking? She's not looking very thrilled. She's saying, oh my God, I'm stuck 24/7 with him now, okay? He's going to be here all the time. And that's the reason, real reason that when men don't live very long after retirement, because their wives start poisoning them. You need a lot of tender, loving care. And remember, ladies, there is only one rule. I am your wife and your best friend. Since I'm two people, my opinion counts twice as much as yours. As long as he understands the rules, life will be very simple after retirement. This is a question people say, what will you do now that you're retired? You have to fill up your days. It could be anything. Looking forward to something is the secret to happiness, and I strongly believe that every day of my week. And it's not little work. It doesn't have to be specifically academic or anything. It could be anything. It could be learning a new Thai recipe. Japanese people, when they were the ones who lived long, were asked what is the reason for their longevity, and they said it's ikigai. Ikigai is getting up in the morning with a purpose, getting up in the morning with happiness and saying, oh, I'm going to do this. It could be just visiting your grandchild. It could be something as simple as that, or I have to write this chapter for this book. It could be anything, but there's a purpose in your life. Someday we will all die, Snoopy. Charlie Brown says to Snoopy, but Snoopy, a very cool character, says, true, but on all the other days, we will not, okay? There's a very Thich Nhat Hanh story which I love. He's a Zen master. He said that this man got up at 8:39 at night and he had this terrible toothache, dentists are closed, no hospital was open, and he said, oh my God, if this toothache was not there, I would be in paradise. But he forgot the 364 other non-toothache days when he actually was in paradise but didn't enjoy it, okay? So enjoy everything that you do. I leave you with a sunbeam to warm you, a moonbeam to charm you, a friend by your side so nothing can harm you, because friendship is something really, really keeps you going. A good friend, nothing can substitute for that. May you always have work for your hands to do. May your pockets always hold a coin or two. May the hand of a loved one always be near you. And may your heart be filled with gladness to cheer you. So you have to rethink your life. Nobody's going to do it for you. You have to renew your goals and your passion. And at one point, you have to decide to reinvent yourself. Thank you very much.